Just housekeeping for the washrooms on this corridor right up to the end. On my left side, there's a corridor right up to the end. That's where the washrooms are. Eh? It's 10:30 and we are starting. Our keynote lecture today is being delivered by Professor Ari Kumarasamy. Professor Ari Kumarasamy is an OBE, that is the Order of the British Empire. He's a senior research fellow at Green Templeton College, University of Oxford. Ari is a professor of gynecology and reproductive medicine, University of Oxford. Apart from that, he's a director of Tommy's National Center for Miscarriage Research at John Radcliffe Hospital. He received his undergraduate medical education from the University of Birmingham and completed his subspecialist training in reproductive medicine and surgery at Guy's Hospital in London. His research portfolio is very, very thick and wealthy. He has been either a PI or a co-PI in numerous national and international multi-center randomized controlled trials. Some of them are the PROMISE trial, which was published in the New England Journal of Medicine in 2015, where they explored the role of progesterone in women with unexplained recurrent miscarriages. The WHO Champion trial, where they studied the effects of heat-stable carbetocin to prevent postpartum hemorrhage, and many others. The one that has had, and we use it, is the emotive trial, where the results showed a 60-65% decrease in postpartum hemorrhage when we use drapes, and also the use of uterotonics. Professor Ari Kumarasamy will deliver a lecture entitled Recent Advances in Maternal Health Interventions for Combating Preventable Maternal Deaths Due to PPH. There is a QR code which will be displayed, and please, if you can display the QR code, please let us go on that QR code. It's a survey which Professor Kumarasamy would like us to take, and then we'll do some answering later on. Professor Kumarasamy, welcome very much from London. It is cold in Nairobi as well. I know in London it may be colder, but we are happy that you are here with us, and the floor is yours. Thank you.
Good morning, and thank you so much for the wonderful introduction. I'm sorry that I'm not there in person, but hopefully in the future I intend to be there with you all in the room. So over the next 20 minutes or so, I am delighted to be able to share some really profoundly important recent advances that changes the landscape of how we see postpartum hemorrhage. What do we mean by postpartum hemorrhage? How do we prevent postpartum hemorrhage? How do we diagnose postpartum hemorrhage? And indeed, how we treat postpartum hemorrhage. So hopefully this would be an exciting and highly informative and instructive 20 minutes. So this is the agenda. We are going to look at a new definition for postpartum hemorrhage. This is the WHO FIGO ICM definition, and this is an evidence-based definition that replaces the definition for postpartum hemorrhage that we had previously. Then we will look at the approaches for prevention of postpartum hemorrhage, and there is new thinking there that is important for high-risk patients. And then, of course, we would look at diagnosis. Diagnosis is so central to everything that we do, isn't it? Because unless there is diagnosis, then we don't identify which patients need treatment. And without treatment, it's difficult to improve outcomes. So really, it is the starting point. So getting the diagnosis right is absolutely fundamental. So we will talk about that. And then, of course, the treatment is what we would finish with. Okay. So the current prevailing definition for postpartum hemorrhage is a blood loss of 500 mils or more within the first 24 hours after childbirth. Now, this has been around for a long time, about 7 decades, in fact. But where does it come from? Well, this is a convention-based definition, which means a group of experts sat together and decided that we need to have a definition for postpartum hemorrhage, and this is the definition that they came up with. And that is okay. When you are faced with a new disease entity, you need to be able to define it. And the starting point could be the experts coming together and defining it. But then, as evidence accumulates, you start to develop definitions that are more in line with the evidence. So, a step up from the convention based definition is what we call distribution based approach for developing a definition. So, here you can think of, say, blood loss. Blood loss for a given patient could be 100 mils, 200 mils, 500 mils, 1,000 mils, and so on. And so, for a population of patients, you can plot the distribution of blood loss, right? And when you plot the distribution of blood loss, you get a distribution curve. And then you can say anyone who has lost more than 2 standard deviations above the mean, or more than the 90th centile in terms of the blood loss distribution, is whom we would call postpartum hemorrhage. So that is based on data. So that's better than convention based. But the problem there is that 2 standard deviations above the mean or 90th centile or above that, how does that relate to prognostic outcomes? What does it mean for the patients? It doesn't inform us about the prognosis. So this is a step up, but doesn't really quite get us there in terms of an evidence-based definition. A step up from that is prognosis-based definition. This is where we begin to relate the variable of interest, let's say blood loss volume, to prognostic outcomes like the patient needing blood transfusion, having laparotomy, or indeed, dying from postpartum hemorrhage. So this is more meaningful because whatever definition we choose is related to prognosis. The final approach is therapeutic effects-based definition. So this is where what you do is that you have one definition, perhaps you have another definition, you might have a third definition, and you put them to test head-to-head randomized trials where you can see, does the use of a particular definition result in better outcomes? So this is the kind of ultimate level of evidence in terms of definitions. So the current definition that we have then is really based on convention based. So we took it further, right? And this work was published in the Lancet. It was fast tracked and published a few months ago. And this was work that was done in partnership with the World Health Organization. And we also looked at the therapeutic effects of using different definitions. And that was published as a Cochrane review, and I will take you through that too. Right, so let's look at the prognostic evidence then. So what we did here was that we did an IPD meta-analysis, individual patient data meta-analysis. And we looked at various clinical markers like volume of blood loss, pulse, blood pressure, shock index, all of these variables of interest. And then we looked at how they related to prognostic outcomes like blood transfusion, surgery for PPH, ITU admission, and death. Okay. And what we wanted to know was to decide on a set of variables and thresholds that gave the best prediction for all these poor outcomes that could result from excessive bleeding after childbirth. Now, before we looked at the data, we did an important international survey, right? So WHO led this and they did this. And the survey was this. We asked practitioners throughout the world, if you were to have a new definition, what do you expect out of it? This new definition need to be able to capture as many patients as possible who would go on to suffer poor outcomes. But what is the level that you would be comfortable with? If the new definition captures 80% of those who would suffer poor outcomes, would you be happy with that? Would 70% be okay? Would 90% be better? And so we put this question to them, and the answer that emerged was 80%. So what people said was a new definition need to capture at least 80% of people who would go on to have poor outcomes. Okay. So we call that prognostic sensitivity of 80%. So bear that number in mind. Okay, so we then went and did the work, 12 studies, more than 300,000 patients, and the findings were really interesting. So when we look at the existing threshold of 500 mils, which we all use, the prognostic sensitivity turned out to be 76%. So it's less than the 80% we were looking for. If we were to lower the threshold, the blood loss threshold for defining PPH, to 300 mils, the prognostic sensitivity jumped up to 84%. That's really good. But this increase in prognostic sensitivity came with a cost, and the cost was a loss in prognostic specificity. So this meant there were lots of, false positives, and we would be treating a lot more patients needlessly if we were to lower the threshold to 300 mils and leave it at that, right? So we couldn't have that. So we looked at the data carefully to see whether we can find a way out of this. And the data showed us the way. And what the data showed was that if you used 300 mils, but combine it with abnormal vitals, so a pulse of more than 100 mils, a systolic blood pressure less than 100, or a low diastolic blood pressure. If you were to combine the two, then you had excellent prognostic sensitivity, 87%, but without really compromising prognostic specificity, 71%. So this then formed part of the new definition. Now, we also looked at therapeutic effects data. This is the Cochrane review that I mentioned. And what we found was that using 300 mils, but combined with abnormal vitals as part of the criteria for defining PPH, didn't result in us treating too many patients. So this new approach of using 300, right, plus abnormal vitals, as well as 500 mils as the backstop or safety net, um, gave a treatment rate of around 12%, but the older approach of just using 500 gave a treatment rate of 14%. So really there wasn't much difference there. So this didn't result in us treating far too many patients unnecessarily. And so this now is the PPH definition by WHO, which was endorsed by FIGO and ICM. So PPH is now defined as an objectively measured blood loss of 300 mils or more with any abnormal hemodynamic sign, that is pulse more than 100, shock index more than 1, systolic blood pressure less than 100, or diastolic blood pressure less than 60. That's one part of the definition. Or indeed, an objectively measured blood loss of more than a 500 mil, regardless of what the vitals are. Okay, so that's the kind of safety net definition. So we have a new definition for postpartum hemorrhage. Now, what this means is that we would be catching women earlier, particularly women who are likely to be anemic, who are likely to become decompensated earlier. We're going to get them early and treat them early. So the outcomes would be improved for the kind of really at-risk patients, people, women, for example, with anemia. So this is the new definition that you should be using in practice. Okay, let's move on to prevention of postpartum hemorrhage. So there is a network meta-analysis that we did to look at what is the best way of preventing postpartum hemorrhage. Now, when it comes to pharmacological prophylaxis for postpartum hemorrhage, there are many options. You've got oxytocin, which is what we use and which is what WHO has recommended for many years. And then you've got misoprostol, you've got ergometrin. You can combine the ergometrin with oxytocin, you get something called symptometrin. You can combine the misoprostol with oxytocin, and there is carbetocin, as you know. There is also the heat stable carbetocin. So these are all options. So our question was, well, which one is the best of these to prevent postpartum hemorrhage? So a network meta-analysis is one form of meta-analysis which is really great because what it does is that it brings different comparisons under one roof, one analysis, and then it's able to rank all the various drugs or drug combinations in order of effectiveness. Okay. Now, what you see here is called a network diagram, and this simply tells you all the various drugs that have been compared. They are the nodes given in blue, and the lines connecting them represent the comparisons. And if the line is green, that means there are high quality studies informing that comparison. Orange means moderate quality. Red means, we are not so certain about the quality of the studies. And the numbers that you see are the number of studies that make this particular comparison. But the beauty of this is that it brings everything into one analysis. So we did that, and this is what we found. So this is called a rankogram. Rankogram, as the name suggests, ranks all the treatments in order of effectiveness. So the treatment that is comes out most effective here is actually a combination treatment. Misoprostol and oxytocin combined is the most effective. Second most effective is also a combination treatment, ergometrin and oxytocin, in other words, sintimetrin. Third is oxytocin and carbetocin. You can see the graphs for them are very similar. So the third is oxytocin or carbetocin, and then come all the various options. So if you are choosing a single drug, then choosing oxytocin or carbetocin is absolutely fine. But if you want the best option for prophylaxis, then you need to start to think about the combination treatment. Okay. So this resulted in a WHO recommendation, which was that for routine prophylaxis, you can indeed give either oxytocin or carbetocin. Oxytocin is fine, but if there is any issue with cold chain, then you would have to think about carbetocin because that is heat stable. But for women who are at high risk of postpartum hemorrhage, you can now consider giving combination prophylaxis with oxytocin and misoprostol. So this is the new recommendation from the WHO. But this leaves us with the question, who are at high risk of postpartum hemorrhage? So we did a piece of work. We systematically looked at the literature, and this was again fast-tracked and published by the Lancet. That gives you all the strong risk factors for postpartum hemorrhage, moderate risk factors for postpartum hemorrhage, and weak risk factors for postpartum hemorrhage. And the strong one, I'm not going to take you through each and every item. I'm very happy to share the slides with you. You can have a look at this in your own time. But important causes like anemia are in there, all right? And in such patients, you might want to consider dual prophylaxis. Okay. Let's move on to diagnosis. The problem with diagnosis is that we don't get it right when we visually estimate blood loss. You can do this simple experiment in your own labor ward. Prepare known volumes of fake blood, soak it up in swabs or linen, and ask people to estimate how much blood loss there is. And you would see there would be a whole range of numbers. So the preparation A here is 600 mils. And you can see people were calling out different numbers all the way from 200 mils to 2000 mils. That's what you see in the post-it notes there. We as human beings, we haven't evolved to be able to estimate blood loss. So we need to accept that we can't really do this. So what can we do then? Well, okay, before I go into that, so that was just an anecdote, a small experiment you can do in your own unit. We looked at large data set from the Champion trial, 30,000 patients, more than 10 countries, where we had objectively measured blood loss, blood that was collected in a drape, and then whether the clinician diagnosed PPH or not. So we were able to compare these two factors. And what we found was that in patients who've lost 500 to 600 mils, only a third had been diagnosed as having PPH by that stage. And even more worryingly, even when somebody has lost a liter, we still hadn't picked up that as a PPH in about a third of the patients. So we really aren't very good in diagnosing PPH through visual estimation. So the misdiagnosis is the area above the curve, and that was about 47%. So visual estimation misses 47% of PPHs, on the delivery suite. We confirmed that here in the UK. This is true in every country, really. It doesn't matter how well trained you are, you are going to be missing postpartum hemorrhage if you rely on visual estimation. And we confirmed this in the emotive data. over 160,000 data points, 52% of cases were missed, right? So we cannot visually estimate. So what is the solution? Well, the solution, there are several, but the one that we went for, because that had the greatest evidence, is to use a blood collection drape. And the idea here is that after childbirth, you keep the drape for about an hour under the woman, and the blood goes into that. She doesn't need to be in this position. She can be on the side. And then you are able to read off how much blood has been lost. And we recommend that you read off every 15 minutes or so, in the first hour after childbirth, and that then gives you the actual blood loss, and then you are better informed. And when you use the blood collection drape, what you find is that you miss very few cases. We found that you miss about 9% of cases. You might be wondering, how can you still be missing cases? Well, blood collection drape is fine, but someone needs to go and look at what's in the blood collection drape. So if that is not being done because the staff are busy, or there are, some other problems, then obviously you can still miss postpartum hemorrhage. But you can see it is a massive improvement from visual estimation. Now, this inaccuracy of visual estimation, we've demonstrated it through other studies also. There are some 18 studies with nearly 300,000 patients that shows visual estimation sensitivity is only 22%, but the blood collection drape sensitivity is about 93%. Okay, so based on this now, the WHO recommends that for all women giving birth, routine objective measurement, and the word objective is the key here, should be performed. And you can do that using, for example, the calibrated drape for vaginal birth, right? But what about cesarean section? So here, again, we can visually estimate, and we know, we can look at the swabs and try to work out how much blood there is, but we know that that's going to be inaccurate. We can look at the canister, but the canister fluid is contaminated or mixed with amniotic fluid, and so that can confound the results. You can be weighing the swabs, so that's gravimetric. You can mark when the amniotic fluid volume suction finishes and blood suction starts. So that is possible. So this is the gravimetric, volumetric approach. Or there is a technology called Triton, calorimetric, where you essentially take a swab that is soaked with blood and you show it to the camera, and it will estimate the blood loss, and it will give you an ongoing tally. And it can also be pointed to the suction canister, and it would again tell you the blood loss. So we are studying this. We don't know whether this works or not. And you are doing this research in Kenya also, and we should have an answer as to whether this is the way forward for early diagnosis. So there are some exciting new developments there. But let me finish with treatment. So for treatment, for long, the problem that we had is what we call sequential approach to treatment. Now, if you have a headache, it's completely fine for you to try some paracetamol, right? And if it works, great. If it doesn't work, you can take ibuprofen. If it doesn't work, take something strong. This is what we do in medicine. We take sequential approach. We don't give all the treatment at once. But the problem, and that is okay, but the problem with bleeding and this sort of sequential approach is that time is lost, and the ticking clock is the determinant of outcome for a patient who is bleeding. So WHO had looked at this and had come up with a bundle whereby the idea was that if you think that a woman is bleeding too much, give her all the effective treatments in your armory in the hope that it stops the bleeding, and that's the end of that. And so the bundle was called Motive, and M is uterine massage, O is oxytocic drugs, either single or double or whatever you normally give, tranexamic acid. Intravenous fluids need to be considered, and examine the patient and escalate the care if needed. So this is the Motive bundle. And E is the early detection using the blood collection drape. And there were a set of escalation criteria for refractory bleeding also. So this was the kind of emotive intervention. Now, this is great idea on paper, but does it work in practice? So we put it through a large trial called the emotive trial, which Kenya took part in. So Nigeria, Kenya, Tanzania, and South Africa took part in it. And it was a monumental effort with 80 hospitals, 4 countries, as I mentioned, more than 200,000 patients, and it gave a phenomenal result. So when we looked at the primary outcome, which was severe postpartum hemorrhage, objectively measured blood loss of more than 1,000 mils, so nobody would question that that is not an important outcome, laparotomy or maternal death. We found that in every country, the rate came down, and overall it came down from 4.3% to 1.6%. In other words, 60% reduction in the primary outcome. So this was fast-tracked and this was published. Transfusion rates were reduced and maternal deaths were also reduced. So we have a new approach for treatment also, which is the emotive bundle. And we are developing something similar for cesarean section called the e-master. And hopefully over the next couple of years, we would see whether that approach also works in the way that emotive did. And a lot of what I've discussed with you has now recently come out in a Lancet series on postpartum hemorrhage, which is available on the Lancet website. And so please, if you need to find more, visit the website and you can get the information. And yes, if you could please do this survey. We are trying to find out if emotive is being practiced widely in your facilities, and this shouldn't take more than a minute. It's only a few questions. So if you could do this survey, we would be tremendously grateful. And with that, I would conclude my lecture. Thank you.
And we hope that we'll be able to. We're actually inviting you for our run in September 27th. I hope you'll be able to join us.
Thank you so much. I'm sorry, I couldn't hear anything for a while, but I'm able to hear now.
Okay.
And I thank you so much for the invitation. And if I'm able to, I would certainly come. Thank you.
Thank you.
Appreciate that.
Thank you. Thank you very much. We really appreciate your lecture and what emotive is doing in reducing our maternal mortality rates. And I'm sure that we'll continue practicing it and making sure that it's rolled out properly. And our Ministry of Health is on board, and we are happy that we have interacted with you today. Thank you very much.
It's a real pleasure. Thank you so much. And I wish the rest of the conference goes really well. Thank you.
Thank you, sir.
Thank you.
So as we continue doing the survey, our next speaker is somebody who is my friend. I think all of them are my friends. She's a teacher. She has taught at the University of Nairobi. She has been a practitioner for a long time. She's a mother. And she has been, or she was, the youngest president of FIGO. You know what FIGO is, isn't it? For some of us who don't know, the hackathoners, maybe they don't know. FIGO is a international federation of gynecologists and obstetricians. It's an umbrella body that all societies, or almost all the societies in the world, are affiliated to. Actually, I'm at the university because of Professor Kehara. That's why I say she's my friend, and I'm really happy that I have this privilege of introducing her. We know that we are here because of mothers. We know that we are here because of ladies. Without ladies, we could not be here. Ladies, good morning. Ladies, good morning. Hello, ladies. Can you hear me? Thank you. We are here because of ladies, and she is doing something which is extraordinary, and that is Femtech, Women in Technology. And I would like to invite Professor Kehara to come and tell us about the role of Femtech in transforming women's health. Professor Kiara.
Good morning, everybody. It's post-tea, so you can make it a little bit louder. Good morning. Now, I'm a very biased woman for the simple reason everything has been male-driven. Ladies, do you agree with me? Aha. Now, I have no apology. We are talking about femtech, feminine technology, not male tech, Prof, not male tech. And you will actually get to see why I'm selfishly looking at it this way. The role of femtech in transforming women's health. And I'll go straight. I don't want to do learning objectives. No. I want us to begin to put the context of where we are in health today and what we should be focusing on. Women are known disproportionately compared to men. We spend 25% of ourselves in ill health. Why? We take care of our husbands and partners, we take care of our babies, we ignore our own health. And this is a global statistic. We are different from men, and I'll belabor there. At puberty, the man forms the male hormone, and he breaks his voice, starts to grow his beard, and starts to look for many more girls to have relationships with. The woman, slightly different. The hallmark she can be a mother is actually the beginning of menstruation. And then you see this voluptuous body. The breasts develop, the hips develop, but she also gets a higher pitched voice compared to the man. So we're differently wired by hormones, our physical being, and even our mentation. And then we have unique entities for women. I'll mention a few. One, there's no single man in this room who'll ever get the privilege of giving birth. That's purely ours. There's no incidence in which I will see a man with fibroids, or he will suffer endometriosis, or will suffer from menopause. And please mark that word, men-o-pose, okay? On a light note. So we have unique entities in our health. But what do we want to see for all of us? Primary health coverage. I'm starting there because we cannot afford to treat disease. We should be preventing it, and we should be giving health promotion. Upstream, as I put it. Universal health coverage. For those of you in the unfortunate circumstance, you end up unwell. Can we be able to treat you without you going through financial hardship? Access, equity. And for me, that's critical. When you think of Mama Mboga, who has to toil every morning and can't get an opportunity to get health care, or the woman in the rural village who doesn't even afford transport, let alone money to even access the SHA. So these are things we've got to think about. Addressing of emergencies, emerging diseases, and humanitarian crises. Let's all reflect. We're in wars in a lot of our nations, but a lot of people are suffering quietly. Most of all, women and children. So yes, Femtech is with us, and it has been with us from 2016. But in Kenya, we're only beginning to look at the policy environment for it this year. So we're catching up. But it's not to mention, we have actually been using Femtech, and I'll show you. But we have hurdles. And without the necessary program and even including it in our routine practices, we stand to be left behind. And the dynamics require the following: capacity building of healthcare professionals, public awakening like we're doing today, and even looking at the entrepreneurship, so the biashara sense of Femtech. But what is it? What is it? When you talk of telehealth, teleconsults, telemedicine, you're already on femtech. When you're having the wearable devices that you put, the smartphone, which even shows you how many steps you're making, how your heart rate is behaving, or your BP monitoring, that is still femtech. When you have monitoring of patients from a distance, we're even advancing as far as cardiac disease. Pacemakers are being monitored from afar. So when I'm looking at point of care ultrasounds being done in Nairobi and I'm reading it off in Nakuru or Mombasa, that is still femtech. Rapid point of care diagnostics, we're moving away from things being done in the lab to having little strips that you can look at. Most of you know the glucometer and the glucose testing. Most of you also know about the HIV, the syphilis and hepatitis testing. We're doing this on small little strips, and this can be done even in your local village. Digital therapeutics. I'm sure most of you know this dawa, mobile dawa. How many of us know it? The bodas that carry the medicine and bring it to your homes. Some of you may know it. During COVID, when there was lockdown, a lot of people used that system in which to get the therapies that they needed. Electronic health records is one of the beginning things that you must have in place. So the digitalization that was spoken to by the PS and even Dr. Serem, it's critical that we begin to embrace ICT. Mobile health applications. So a lot of the girls, you have your menstrual apps, you have your fertility apps. The list goes on. There are a lot of things evolving. Then real-time data. And I really want to focus here. If we're going to do any acceleration on Ewene and RRI, we have to be on real-time data. I will pause here. This morning, how many of you have looked at even the records of how many mothers have died today? How many newborns have died today? In the last 1 week, we've had perinatal loss of 488. If that doesn't bother us, then what does? And then artificial intelligence. It's a buzzword for a lot of you. But for some of us, predicting things, precision medicine, beginning to use AI as even complementing you, and particularly the medical students of today, in getting real-time information. You don't have to go to a textbook anymore. You just need to go to ChatGPT or to Claude and the other programs that do exist to help you. But why do we want to emphasize on this femtech? I've talked about the hormonal milieu or environment of women and how things change from adolescence to women of reproductive age to perimenopause, menopause, and the aging woman. So we take on a life course approach. That is femtech. We're not looking at it as a static issue, but a continuum of care. What should it be doing for all of us? Disrupting our lives. How? Improving care, enabling self-care, improving diagnostics, addressing stigmatized and vulnerable populations, and also we need to remember it must be culturally sensitive. What do I see as the future of femtech? It'll form clinical intelligence. It will give digital maternal safety, precision public health, and compassionate digital care. I like the way Oluga's emphasized about respectful care. We've got a few examples. I won't belabor to some of them, but this is the one everybody seems to speak about, the ultrasound, and now the AI on top of the ultrasound. So even Mama Boga can flash to get to know what is happening with her baby. But femtech must be linked with a health system. Beyond that, what do we expect as the impact? Earlier identification of pregnancy complications, reduction in postpartum hemorrhage, improving hypertension and diabetes detection and management, better maternal nutrition, enhanced provider competence through digital learning, stronger MPDSR systems, continuity of care for all women, improved maternal and newborn survival. But Femtech is not just for mothers who are expectant. It goes beyond it. I won't read everything, but you need to think of some of the entities we're beginning to introduce in gynecological problems, looking at biomarkers for detection of cancers, biomarkers for endometriosis, and the list goes on. But we also need to recognize the value in economics. Why do I say this? And I want my colleague from MOH to listen. We don't need women to always come and form those protracted queues in hospitals. Let women take charge of their bodies at home. So we're moving care to the home. I can do my rapid diagnostic test at home, and then based on the report, consult with the consultants. What would you have done? Freed the hospitals to deal with emergencies. And for the individual, empowered them in their health. I'm a firm believer. Every morning I should come out of my washroom. I should have tested something on my hair, something in my mouth, something from what I leave in the toilet. That's the kind of medicine we should be practicing. So that I'm communicating with the doctor when I see an abnormality. But my self-care should be the first, self-advocacy for health, the upstream I spoke to earlier on. So in this vein, we started doing something called the Femtech ecosystem of Kenya. And in it, we're looking at the legislature and policies, we're looking at the environment, we're also looking at the issues of patient-centered care, and even the clinicians taking charge. The hackathon that's here, it's actually clinicians looking at health from a different perspective, but importantly, even looking at data science, and even then looking at gender empowerment, gender transformation. So in conclusion, ladies and gentlemen, Femtech isn't going anywhere. My hackathoners, where are you? The young ones, young and restless, keep going. I want that energy harnessed for Femtech. For the older guys like Kireki and I, we have to catch up because you're otherwise going into renegaded medicine. Right now, we're looking in the policies and we've recognized there are gaps, much as we have a very strong digitalization agenda in Kenya. We have clearly recognized we must put Femtech on the ground. We must capacity build healthcare providers and create the public awareness that is much needed. We also need to notice that we will be moving to predictions. Health will be yours for you to own. Know about yourself, predict your own risks. Prevention should be key, and personalization must happen. And then for integration of AI and digital health, there's the good one and there's the bad one. For us, Femtech will actually resolve a lot of issues that we need to be cognizant of to make a difference. Thank you very much.
Thank you, Professor Kihara. When she was the president of FIGO, she was my president out there. But when she came to Kenya, I was her president. And we agreed in the morning that ladies are not old, Professor Kihara. So mature ladies like Professor Kihara. Thank you. I would like to remind us that whoever did not sign at the registration desk, if they can please do that. And some of the registrations are not complete. We need your email address because some of you just wrote your name and the phone number. Please, during lunchtime, finish the registration. This is for continuity, for any information later on that we'll be able to send to you. I would also like to remind you that with this inaugural PPH conference, we have our PPH run in September 27th. And our vision as the PPH Foundation is that 1 million people will run for her. Sinawezekana. Like our brother, we call him our brother Obama. We can do it, isn't it? Yes, we can. We can do very little without cooperation. We can do very little without partnerships. Partnerships are important. We are here because of partnerships, and we will move this agenda forward because of partnerships. Dr. Serem in the morning said that the Ministry of Health, the government, whether it's the national government or the county governments, cannot solve this problem alone, and that is why we're here. So I'd like to invite my brother, Professor Obimbo, to tell us a little bit about the value of partnerships in safeguarding maternal health.
Thank you very much, and good morning once again. For those of us who've been to Zimbabwe, there is a small town there called Chitu Town, also called Chitungwiza. And the people who inhabit that area are called the Shona people. They have a very good saying that a person is a person because of the people. Do you agree with that? Yeah, absolutely, that's true. If you go to the west, is Malawi. There's also a very popular saying there that you start doing things early in the morning, and so that when you see your shadow late in the evening, you know you've achieved quite a lot. Now, last year, my mentor, Professor Kihara, gave me an opportunity to be a keynote speaker at the FIGO conference, speaking amongst over 6,000 colleagues, quite intimidating crowd. And we made an announcement that from our initiative of ending PPH, we'll be able to hold our first international PPH conference on 22nd of July 2026. It's happened, but it's not going to be possible. It was not going to be possible without the support of the very erudite members of the communities, members of the pharma industry, members of every sector that have supported us, from the ministry, from the people around us, because climbing this mountain of scholarship, academia, excellence is not possible without we, the people. So I'd want to invite a few of our partners who've really supported us to maybe just give 2 to 3 minutes remarks on their perspective about maternal health. I know they do different works, from microbiome work, from the manufacturing of histobocabetocin and so forth. So I'd want to call upon, in that order, Mr. Parit Mehta, we work with at the AfriBiome. And then I'll invite Dr. Jalango, who's been our great supporter, especially ensuring that we get educated on issues of PPH, and she's from Fairing. And then I'll have from ICRH, our partner that we work together, Okoa Mama, Okoa Mtoto initiative. We have Dr. Charles Undieki and Melanie. I think if we have those individuals in this room from ICRH, our colleagues, Dr. Charles Undieki, and Dr. Charles Undieki is here. Right. Yeah, so then we'll have also a representative from the Midwife Association of Kenya, who's been working with us. I know Tekla is here. She'll just say something. And then finally, our colleagues from Chason, doing point-of-care ultrasound on obstetrics from China, and they've also been working quite a lot with us. So over to you, Mr. Parry.
Good morning, dignitaries present, professors, doctors, ladies and gentlemen. We are immensely honored to have been given this opportunity to participate in this inaugural PPH event, and our thanks to to the organizing committee of this to allow us here. I'm the managing director of Prisma Pharma, FZE. It's a company that's based out of the UAE. Our company was born on a simple vision to be a ray of hope and provide affordable quality care to the patients that we serve. Over the past 2 decades, we have built our portfolio of products with a particular interest in microbiome-based therapies, particularly pre, pro, and postbiotic products, focusing on gastrointestinal health, mental health, and maternal health. Microbiome science is changing how we understand human health. The microbiome, the vast community of microorganisms living in and on our bodies, plays an important role in digestion, immunity, metabolism, inflammation, and protection against infection. Its relevance to maternal health is especially promising. During pregnancy, a woman's body undergoes major metabolic, hormonal, and immune changes. The microbiome is a part of this adaptation. Research suggests that the disruptions in the microbial balance may be associated with adverse pregnancy outcomes, creating an opportunity for earlier and more personalized care. In the future, microbiome-based insights may help us identify risks sooner, tailor nutritional and preventive support, and develop safer treatments that work alongside established antenatal and obstetric care. The effects may also extend beyond pregnancy. A mother's microbiome can influence a baby's earliest microbial exposure during birth and breastfeeding, potentially shaping early immune and metabolic development, highlighting the close connection between maternal well-being and newborn health. Much of this science is still emerging, and microbiome-based treatments must be rigorously tested for safety and effectiveness, particularly in pregnancy, but the potential is significant. Microbiome science offers a new way to understand maternal health, not simply as the absence of disease, but as a dynamic relationship among the mother, her environment, and the biological communities that support her. By combining this science with high-quality, equitable maternal care, we can move towards healthier pregnancies, safer births, and better outcomes for mothers and children. A mother, after all, carries the extraordinary power to bring new life into this world. Thank you.
Good morning, ladies and gentlemen. All protocols observed. It's a great pleasure to be here this morning. We have a vision at Ferring Pharmaceuticals, and I work as part of the initiative that fosters a vision that would see us saving the lives of 30 million women by the year 2030. This is the initiative called Project Family Safe Birth. The journey begins in 2013 with the Champion trial, which found that our product, heat-stable carbetocin, is non-inferior to oxytocin, but has a peculiar aspect that it is heat-stable and therefore relevant to the circumstances that exists in low and lower middle income countries. So together with the WHO, began a journey in 2023 that still goes on, and also with the support, technical expertise from MSD for Mothers, we run this project to impact over 80 countries in low and lower middle income countries. I joined halfway through this journey in 2020 during COVID, and have been in this project for the past 6 years. Over the past 6 years, Ferring has a commitment to the mothers in the low and lower middle income countries to provide heat-stable carbetocin at an access price. It is a colossal task that we cannot do on our own. So we value partnerships. Together we can achieve more. It is a real delight for us at Ferring to be able to impact the SDG goal 3.1. And in this respect, there are a lot of things that we do to ensure that mothers get heat-stable carbetocin. Among them are the regulatory requirements in the countries, ensuring that the policy is in place, and thereafter building capacity in the supply chain and in healthcare professionals in the use of heat-stable carbetocin. Our journey in Kenya began in 2020 and is still going on. The country, with the help of the ministry and various partners, including COGS, Midwives Association, and PPH, GPAGO, CHAI, PATH, Luala, and there are lots of them who have impacted our process. Women, for a long time, have been dying because they have not been prioritized. But it's delighting and hopeful that now they are in our agenda, in our political agenda, in our development agenda. And so for us is to continue the journey, and we cannot do it alone, as I've already intimated. So we look forward to the partnerships, and we are extremely glad to be a part of this initiative and the first international PPH conference here in Nairobi. I am really, really happy to see the progress that we have made amidst various challenges that we will continue to tackle to ensure that when a woman enters a facility to give birth, she lives alive to take care of her children. So I'm grateful for the partnership with NPPH, with the PPH Foundation, the ministry, and all the local partners who have helped us make that vital difference as we avail heat-stable carbetocin for the public sector. Thank you.
Good morning. Yeah, I'm Dr. Charles Ondekio Tuori. I work at International Center for Reproductive Health, Kenya. So we are very proud to be associated with the first international PPH conference. And why so? Because at ICRH, we champion the rights of women, ensuring that we have all women able to access their rights. And we do this through research and also through policy translation and also supporting the government and the other partners. And when you talk about PPH, we really need to think about the whole continuum of care, from prevention and also even as what are we doing in terms of anemia management. Anemia becomes a very key component that is affecting the outcome of mothers who have PPH. And we now have a lot of evidence from the woman trial that if we don't address anemia, then we'll not be able to reduce the deaths from postpartum hemorrhage. And also, as we address anemia, that means we address issues like nutrition, which is quite important in ensuring that as women get pregnant and go into delivery, they're in their optimal health. The other area that as ICRH we are doing is we are currently conducting a study in abnormal uterine bleeding. As we all know, abnormal uterine bleeding, in a lifetime, 1 in every 3 women will have abnormal uterine bleeding. And this is an area that at the moment has been normalized. And we really need to do a lot of advocacy to ensure that we highlight. Because if we don't address, for example, abnormal uterine bleeding, then we'll still have women coming into pregnancy who are anemic and will not be able to prevent the deaths due to PPH. The other third area that I really want us to, as we think through, we know the PPH bundle, but for us to have the benefits, from the PPH bundle, we really need to implement it with fidelity. And maybe just a show of hands, for those ones who are in clinicals, how many are implementing PPH with fidelity? It's with a show of hands. Yeah. Thanks. It's good to see. And PPH with fidelity means we start with the E. That is all women who are delivering in our facilities. We have to have objective measurement. That is an area that we really need to improve on if we want to manage PPH. And then the bundle, having all facilities, be it private, faith-based or public, being able to implement the PPH bundle. And we have a very good opportunity at the moment because we are in the RRI period. And this is an opportunity that even the president has flagged off. And as we talk about PPH as a country, and also internationally, this awareness provides us. Awareness is every woman, every newborn, everywhere. Initiative provides us with an opportunity to really demonstrate that these high evidence interventions can work. And I hope that as a country, as we go after the 6 months, we really be able to demonstrate that we've been able to reduce postpartum hemorrhage. So as an organization, we are really proud to be associated with this initiative and really look forward to supporting each one, collaborating with each one of you and partnering so that we can reduce the unnecessary deaths due to postpartum hemorrhage. Thank you.
Good morning, everybody. Thank you. My name is Catherine Shienji. I'm the President Midwives Association of Kenya. I am standing here on behalf of the midwives here and midwives practicing countrywide. I don't know how many midwives are in the house today, by show of hands. Thank you, thank you. A big applause for the midwives. Thank you. We all know that midwives are the first people to identify PPH in our respective spaces. So with that, we collaborate. We don't work alone, and we collaborate with others. And here, as a Midwives Association of Kenya, our campaign is to end PPH everywhere in our country. I know this is a task that all of us are taking, but we need to work together and collaborate and ensure that we are ending PPH in our country. Being the #1 killer of all the mothers that we are having in this country that are dying, most of them are dying because of PPH, and some of the conditions can be prevented in our spaces. We are ready to work with the rest of the team. I am glad that we are part of this initiative, the first conference on PPH. We have been also part of the End PPH run, and we have been participating as midwives in this country. And countrywide, I know the runs have been taking place. So as Midwives Association of Kenya, we are ready to work with all the partners. We have worked with Ferrin Pharmaceuticals, we are working with COGS, we are working with the ministry, and all the other partners that are here and not even here. We are working together as an association. Our task ahead is to find a way and find strategies to end PPH in this country. And that cannot occur with the midwives alone. It will occur with all the stakeholders coming together and collaborating and finding ways to end PPH in this country. Thank you so much, and be blessed.
Thank you very much, Christine. Gina? No, thank you, Christine. I'm called Gina from Chason.
Thank you. Hello, everybody. My name is Gina from Chaisen Medical Manufacturer. We are the ultrasound manufacturer, and we work with Gates Foundation around 2 years and focus on the point-of-care ultrasound together with the AI technologies. I'm really appreciate that today I have the chance here to listen to so many intelligent ideas from the AI-powered ultrasound so that we can help all the ladies here and to have a better life. So for the next step, we will work together with Dr. Moses, focus on the point of care for the women's health. And I'm really appreciate that we can work together to have a better future. Thank you.
Thank you very much, Gina. We have Jennifer from UNES. Is Jennifer inside here? Right. Yes, Pamela, you can come. You're representing Jennifer.
With all protocol observed, good morning, ladies and gentlemen. Yes, my name is Pamela, and on behalf of UNES, UNES is the University Enterprise section that deals with all the income-generating business consultation. So on behalf of the MD and Jennifer, who was around, she's just stepped out, I would like to take this opportunity to thank the organizing committee of the PPH for inviting UNES as part of the university to be here and participate. UNES has various medical units that supports. We have the eye center, we have the dental, we have the major one, which is the consultancy, we have radiology. We also have the geromofuneral parlor, which is under the human anatomy. With geromofuneral parlor, we work in closeness with our academia, the researchers. Prof. Ogengo is here, Prof. Obimbo. We get so much data on the PPH. So I believe this data will help us come up with a strategy, knowing very well that mothers are dying because of PPH. So once more, we are glad to be associated with the PPH Foundation. Thank you so much.
So thank you very much to all our partners. As I always say in Rubavu, Kigali, that a river is only as strong as its tributaries. Let's continue making the tributaries stronger so that the river can gain momentum, and as we said in the morning, to create a true movement that's able to save our mothers and our neonates. So with that, thank you very much. Back to you, Dr. Kirek.
Thank you, Professor Obimbo. Thank you, our partners. Thank you, all of you. I think a year ago, I attended a conference, and in that conference, it was in London somewhere, can't remember exactly, and they had the NHS representative there, and in the NHS, they have a research body. Can you imagine? Kuwa na research body. Yes, and they allocate a lot of money for that research. And what they do, of course, they send out calls for ideas, and there's a committee that sits and goes through these ideas, and they come up with projects which are viable, and they look at those projects, the ones that are viable, and actually push them and make prototypes, and later on send them to industry, and it's a business, it's a stream. Kwani wazungu wako na vichwa mbili? Sini moja? So when I came back, I had a discussion with my brother. I said, look, there's this thing that I saw. What can we do about it? And my brother, as usual, the intellectual that he is, tufanye hackathon. Kasema sawa, tufanye. And this came up, of course, slowly, and we have worked with it, the committee. And when the call came out, actually we were a bit, how will it be accepted? we were surprised, pleasantly surprised, that we had so many people, so many teams which applied. And with Professor Ogengo as the chair of the committee, they went through all these teams and their proposals. And we have come to one of those things that is actually something that is new in this part of the world. To the best of our knowledge, this is the first hackathon that is being held in Kenya, and I think in the south of Africa. Simuchipigie makofi. We have made history and will continue making history. We are here to listen. The judges are here. And we want to hear those ideas that are going to change the landscape. We meet and we talk about PPH, talk about this. We need money. Dr. Serem talked about mobilizing funds and so on. Yes, these are parts of the puzzle. But is there something else that we can add to that puzzle so that we can be able to change what happens, how we deal with PPH, how we can help our mothers, and how we can reduce our maternal mortality ratios? I am not competent to lead this phase. So I will hand this phase over to a good friend of ours, Dr. June Madete, who will conduct this. Dr. June Madete, karibu tafadhali. So, Daktari, the chair is yours, or the mic is yours. And this is one of those moments that we've been looking forward to. Karibu.
Thank you. Thank you very much. And for me, thank you for organizing this. Ooh. And thank you to the organizing committee. This was actually very well done. Innovators are normally assumed to be somewhere in a desk in the back. Then they come up with an innovation, and then the users are like, who told you we need it? So for me, I always tell my students, go to the user, use the data, make the impact. We heard from Professor Kihara the way she said, all those ideas. Now we have like 20 projects. So my name is Dr. June Madete. I'm the director of the Medical Device Innovation Masters Program, the first one in Eastern Central Africa. In Kenyatta University. We were also the first university to start biomedical engineering as an undergraduate. So we have innovators. The problem was, the reason we started the device innovation is the device path, proof of concept to market. People did not know what to do. You have very bright students who can make things, but nobody wants to buy it. You have people who need things, and they're not talking to the people who want to make it. So our master's program is actually both engineers and clinicals together. So yeah, thank you for this. This is actually very important to me. But PPH, I have learned a lot today. Today I was in class. I have learned percentages. I have learned what it is. I've now known a new definition. So today I was in class, and thank you for that. And as engineers, we struggle with knowing that information and getting that information, so this is very important. And I have also felt that increasing access and equity and disrupting, and I've learned things like practical solution, lasting contributions. Sometimes I said we like making a rocket, but it's going to be used once. Why can't we save the lives? As the motive was something very straightforward, but it's something that is disrupting the area. So with no further effect, I'm going to introduce the disruptors. The first disruptor, innovator, moral link, an interoperable, hey. Community to facilitate maternal health integration lay. Afia node. Welcome, Lavin Mumbo. You have 8 minutes, by the way.
Sorry. Good morning. My name is Lavin Mumbo. I am a nurse officer intern at Narok County Referral Hospital. I am the team lead at Afyanod Kenya, and with me here I have my team with our project Moralink. So in Machakos County, we have 398 deaths per 100,000 live births per year. The national average in Kenya is 355 deaths per 100,000 live births. That means that we have more mothers dying in Machakos County. That overlaps with the national average. So today we are presenting Moralink, which is an interoperable community to facilitate maternal health integration layer. And the safest way to handle a maternal emergency is to prevent it before it happens. So having 398,000 deaths per 100,000 live births, we have at least 24.4% of eligible women who skip free maternity services due to transport and financial bottlenecks in Machakos County. And with Moralink, we are aiming at reducing the time in which these women access healthcare services. And our objective looks at the three delays that result to maternal mortality rates, whereby 81% of maternal mortality deaths are involved in the first delay, and that is a delay in failing to recognize the signs and symptoms. And then the second delay, which accounts for 88%, the delay in reaching the healthcare facility due to distance or transport. And 92% is involved in the third delay, which is a delay in receiving timely, high-quality treatment on admission. That means that the moment a mother arrives at the health facility, we do not have the necessary data, we do not have the history, therefore we are unable to deliver specialized services to that particular mother. So our technology focuses on the continuous care model, daily 60-second check-in that is built-in ANC daily check-in for the mother, and the months of symptom vitals data ready before an emergency ever happens. We also have community health promoters who get algorithms, risk-ranked visit priorities every day when they see these mothers. And also, the data is transferred to the county health information systems. That means that they are better prepared for emergencies. They are better prepared to handle maternal and obstetric emergencies. So Moralink is an interoperable layer, and it's not a standalone app or digital device. We have existing digital infrastructure in Kenya, and that is the electronic community health information systems, the county health information systems, and the Kenya Health Information Systems 2.0. So our digital system aims to introduce a layer where the mother takes charge of her own healthcare. So we introduced an interface for the mother where she inputs her own data. She's also able to monitor her own progress in antenatal and postnatal period. And this data is relayed to the community health promoter. It is relayed to the county health information systems. We are able to prepare resources. We're able to prepare services. We know what we're expecting in referrals. We have zero-rated USSDs or SMS and web applications for mothers who cannot access internet. So the mother reports the symptom checklist in the system without needing a smartphone or airtime. We use a rule-based triage engine, flags high-risk pregnancies and automatically alerts the nearest community health promoter, the nearest ambulance, and the nearest hospital. And we have pre-arrival facility alerts, whereby we have verified referrals that reach level 4 and level 5 dashboards and WhatsApp before the mother arrives at the facility. And that means that we are better equipped, we are prepared to handle this mother because we have the history, we have the data, and we have the information about the mother. That means we are eliminating the time that it takes for that mother to arrive at the hospital, and you start taking history, you start looking for insurance, and you start asking questions. So when the mother arrives, you have everything in hand. And the next thing is a unique patient identifier. That means if the mother is registered in Machakos County and she travels to Kiambu County, we are able also to get that data because the system is interoperable to communicate with all other existing digital infrastructures. We also have incorporated the Social Health Authority. As we did our community health engagement with the Machakos County and sub-county public health workers, they confirmed that financial economic hardships are some of the contributing factors as to why these women do not want to access healthcare. So the system is incorporated with the Social Health Authority to eliminate the time it takes to file an insurance claim, to eliminate the time it takes to register that mother to the insurance, the time it takes for the insurance to approve those claims. We have AI POCUS integration, that is the AI point of care ultrasound. We are taking ultrasounds to the mother. For the point of care ultrasound, these are handheld devices that are able to get ultrasound data, that therefore we are able to also know the state of the baby, the newborn, the fetus in the uterus, and monitor it through the system. And the alerts are able to be triggered in case of things like congenital anomalies, abnormal biophysical profiles, and things like that. And we move on to the mechanism of action. From a symptom in the village to a prepared theater. The first step is the mother reports the symptoms via zero-rated USSDs. It can be web applications, and that is after registration by the community health promoter. The second step is triage. So the system has a rule-based engine that scores the mother in terms of symptoms and danger signs criteria for postpartum hemorrhage, preeclampsia, and puerperal sepsis. The third step is the community health promoter alert, and that is the nearest CHP is alerted. Because community health promoters work in villages, they are alerted on the state of the mother. The fourth step is referral. We are trying to eliminate the time it takes to refer a mother from one point to another in the facility. So the electronic referral is generated instantly and transmitted through structured FHIR payload. FHIR is interoperable standard, so it's able to communicate with the county health information systems. And the fifth step is facility alert. That means the referral facility is able to get the data on the patient that is going to arrive. And the sixth step is prepared care. And the clinicians are also able to prepare early enough before that mother arrives at the facility. So we save time and we save life. So the verified referrals trigger real-time pre-arrival alerts on the facility dashboards on level 5 and level 4 maternity wards so that clinicians can prepare interventions early enough. On the continuous record from the mother's home to the antenatal care monitoring portal, from the mother in the community to the community health promoter and to the hospital and the antenatal clinic monitoring, and then to the National Health Information Exchange and the Kenya Health Information Systems 2.0. That means you're also saving time, the time that it takes for us to collect data on maternal health in Kenya. We're also able to predict and promote healthcare. And a modular API first layer that is built for low bandwidth realities. We have the data input, the integration and processing, the action and routing, and the application layer. So the USSD gateway from the data, we secure a server that is interoperable with the health information systems, and then the automated notification engines for alerts, and the community health promoter dashboard. This goes all the way to county analytics. And the build for the mother's current systems that she live out, the adolescent safeguard protocol, we recognize that we have mothers under the age of 18 who are getting pregnant. So these pregnant mothers are also able to be registered, and the certificates are linked to the guardians. And then we have a postnatal vaccination safety net and a rapid UPI onboarding. And this is a message from the sub-county public health nurse that in Machakos, the delay is not just in distance, it is in finding an ambulance, it is in finding blood products, it is in finding the mother's history. Moralink puts that history in a provider's hands instantly and helps, it gets help moving before it's too late. Digitizing the 2 paper records that anchor the Kenyan maternal care, that is the NC handbook, the patograph digitization, and the social health authority. So we integrate the healthcare financing, monitoring of pregnancy and antenatal care. And we switch to the prototype of Moralink.
Hello. So for the prototype, we'll be using a recorded demo. So this is the mother's profile, where she can, I'm sorry, it's going a little bit too fast, but in this page, we have the mother where she can log her daily symptoms, right? Now, based on the symptoms that she'll log, it will trigger now the alert engine. The AI is based on an expert system, a rule-based engine, where it uses deterministic inputs, whereby it won't hallucinate in any way, because it uses rules that have been set, like for certain conditions, this is a possible cause of maybe PPH or reduced fetal movement. So once she has submitted, it takes her back to the home page. But you can see at the alerts page, you can see based on the conditions the symptoms she felt, it triggered an alert. So that's one of the alerts, yeah? So over here, she can view all her alerts. So that one was the symptom that she logged like 4 seconds ago. So also, she's able to so that was the mother's side. We can go over to the community health, to the midwives section. This is forwarded a bit. So in this page, she's able to see her upcoming NC appointments, and she is able to open them as well, such that when the mother comes, she just logs in the details for the ANC. Then based also on those symptoms, the engine might also trigger an alert. Maybe there's a protein in the urine. That's a bell. So it shows her the alerts. There are the alerts. Maya Dickey was the mother that just logged the symptoms. So she's able to see and assess what happened. It tells her where the symptom came from. As you can see, it was from the mother's log. So she can now choose how to respond. She can dispatch, and the hospitals on the drop-down are based on the mother's area. Yeah, so that's our system. Thank you for listening.
Thank you very much. You guys can hear me? I'm a lecturer. I'd like to also mention we have 10 judges.
Oh, nice.
Yes, 10 judges.
That's good.
But since it took too much time, I don't know.
Thank you for your...
Okay, we'll have 2 questions. And then because there are 10, we can't have them introduce themselves, all of them at the same time. So every time they ask a question, they'll introduce. Yes? Thank you.
I'm Jambo.
Jambo.
My name is Mbogo Njehi. I'm a technology venture builder, also passionate about matters healthcare. I have 2 questions for you.
Yes.
You said this is another layer and not another app. there were already 3 other systems that you mentioned. My question is, are those 3 other systems open? Like, do they have APIs that you could then interface with seamlessly to make sure that now your mediation layer talks well with them? That's number 1. Number 2 is you talked about using AI. I'm curious what LLMs you're using on the back. Are they proprietary? Are they offline? Or are you using the common stacks that you're doing an API call to Gemini or Claude, etc.? And whichever the case, how are you dealing with the elements of data privacy, seeing that you're dealing with healthcare information? And lastly, who owns the data and the insight that you then get out? Because we're in the information age, and that's a very curious conversation that needs to be addressed. Thank you.
Okay. Can you take the question? So, to your first question, how we can achieve the interoperability. So, doing research with the team, we discovered that there's a FHIR, F-H-I-R. So it's like a standard for, it's an API standard for hospitals to exchange data. So we can build an API for that, such that when maybe a specific hospital requests data for a specific patient, we are able to supply it in that format. And also, when the trigger is triggered, so we can send, maybe let's say the midwife chooses to send an ambulance, right? Now that's where SHA comes in. So what we do now, we send the information of the mother to the hospital such that they have the information that she needs, that they need, maybe the ID number, her details, blood, such things that might be important for them. So yeah, we have an open API for it.
It's the reverse, in the sense that you have your platform, and there are 3 other platforms. Your county, your Serekali, ETC, your SHA.
Yeah.
SHA is doing the ambulances now.
Yeah.
So do you know if SHA has an open API? Thank you. So it's just taking from the top. So it's the reverse. You can have your own APIs, but I'm curious if these 3 other systems, these other platforms have open APIs that allow you to integrate seamlessly to it. Like I get when you say to hail an ambulance, you know that SHA is rolling out an ambulance service. Are you able to do that programmatically? Do you know if those 3 systems have open APIs that allow you as a third party to integrate into them?
Oh, okay. So for that, I'll go back to the FHIR system. It's an protocol, sort of a protocol that enables this medical system to interoperate such that hospital A wants to communicate with hospital B to get certain information. They can just send
Just for clarity again, you see these are hospitals. I'm talking about the final resting place of this data is with these 3 systems that are operated by, let's say, government. Do those systems have open APIs that would then allow for your system as the orchestrator of everything to finally say, I've got data from the mother, I've got data from the midwife, I've got data from the hospital, but the final place it needs to go to these core systems, whether you're hailing an ambulance or doing a final commit. Do you know if they are sufficiently open? The standard is there, but are they open? You can say there's a standard, but the door is locked. That's my question and my gap.
Okay, to be completely honest with you, we hope so, because the FHIR, it's...
I'll take it. I'll take it. Yeah.
Yeah.
Okay.
Now, for the second...
I mean, it's things that you could now explore to see how to fast track some of these things. Yeah.
The second question.
Because of time, we can have the other questions during lunch. So thank you very much. And yeah, good luck.
Thanks.
Next team is Binti Care, and it's led by Nicole Njeri.
All right.
Sorry, to the previous team, I might have missed this, but how is the mother entering her symptoms on a daily basis? You showed something there, so how is she entering it? And how are you identifying that mother?
Okay, now for the mother, there's a page that she can select every day. There's a form system, like it's a web app.
Okay, how does she access that web app?
Okay, she logs in. Okay, so when the mother visits the hospital for the first time, her account is created. Because you can't create an account by yourself, you need to go to the hospital so that they can create the account for you. Because they do those first initial tests and we need that data, right? So the moment she has created her account, she can now open her portal, right? Her portal, her interface, where she can select, maybe she wants to see the history of the pregnancy, she wants to see maybe the alerts. So now there's a section she can press to just log symptoms every day or whenever she feels like, I'm not feeling well, let me just log my symptoms. So from the list of symptoms, she just clicks and then she submits.
At the facility?
No, not at the facility. Her phone, her computer. Yeah. Is that okay? Okay, I'll see you. Thanks.
Okay, thank you very much. I think we can continue the discussions after. So I will welcome Binti Care. You have 8 minutes, and then we can start.
It's already afternoon, so afternoon. Okay, so Margaret Nkatha experiences severe vaginal bleeding, severe abdominal pain, fatigue, and dizziness. She comes to Meru General, a level 5 hospital in Meru County, and she meets me, Nicole, a gynecological nurse. I take her history, do her physical exam, and facilitate the lab investigations. And we come up with a diagnosis of incomplete abortion. When I was taking Katha's history, I noticed that she hadn't attended any antenatal visit. So this means that she didn't get any prior knowledge regarding the health education pertaining the danger signs. So this is where Binti Care comes in. Binti Care is an integrated mobile app and web app that tracks the woman's reproductive health all the way from the menstrual journey up to through conception, through her pregnancy journey, through the labor and delivery. It also manages through the postpartum for both the mother and for both the baby. With Binti Care, Nkatha is able to access health education, of which she will have had the prior knowledge of the danger signs, of which So with a Binti Care, Nkatha would have been able to have information about the health education pertaining the danger signs, of which this would have led her to seek medical help earlier, because with her case, Nkatha, she didn't have the prior knowledge, which led to the delayed knowledge. Also with Binti Care, she's also able to get antenatal care visit reminders, facilitating her to follow up with the antenatal visits. So the team behind Binti Care, the team lead Nicole Gashingiri, I have my crew here. One member wasn't able to join us for the presentation. I have the front-end web developer, Mercy. I have the back-end developer, Effie, and I have the AI assistant, Newton.
Thank you. So now with Binti Care, Margaret Nkadha is able to, one, she's able to track her menstrual cycle journey. So she can log her menstrual cycle journey, she can log her periods, and automatically after logging her periods, we are able now to generate her ovulation dates, etc. And also, we also have the pregnancy profile. So in case Margaret Nkadha now is pregnant, she's now able to track her pregnancy journey from the antenatal clinic visits. And apart from that, she's also now able to log her vitals and her symptoms as she goes by. At the same time, she's also able to see her antenatal visits that are being scheduled by the doctor. So as you can see for now, she has been able to attend the first one, the second one, and the third one, and now the fourth one is in 11 days. At the same time, she also has a nutrition guidance. She can be able to have guidance based on her pregnancy period or month or week. She has a specialized guidance for that. Beyond that, we also have the postpartum journey. So after delivering the baby, we now want to work with Margaret Nkadha through the whole journey. So she's now able to have her baby profile, and her baby profile, she can be able to see the things like vaccinations. For example, she has not been taking her child for vaccinations, and now you can see she's getting overdue dates in the application. Now, at the same time, in our application, we also have a specialized AI assistant. We want Margaret Nkadha to be able to access specialized AI assistance, and from this, she can choose to share her data with our AI agent or not to retain data privacy. So that's why I can either turn it on or I can turn it off at the same time. So here she can start a new conversation with the AI, and she can ask it as many questions as she wants. So I think we are going to So you get that. At the same time, we also have our AI avatar companion. In case she wants personalized help, she can get to start a call with a personalized AI assistant, and this is like an avatar that is able to record the mood and everything. Hello.
Hello. How can I support you today?
So this is one of the things that we have been able to integrate into our apps. This is an avatar that is able to walk with the mother through the journey. And at the same time, we also have our referral network. So that means that in case of an emergency, she has an emergency alert, that is the SOS alert. She is able to... Oh, sorry. Yeah, so she has the SOS alert. She can be able to trigger an SOS alert, and then that hospital is going to get an emergency with a reference ID for her to get for an ambulance to get dispatched. At the same time, she has access to hospitals, and in case she wants to get a referral to a particular hospital, she can get it. And on her profile, she can be able to see who has been accessing her logs on the doctor's side, and at the same time, she can choose who to share the emergency with in case of an emergency. And she has a personalized care team, and now I'm going to hand it over to Effie to take us through the mothers who cannot access internet through the 2G interface.
So hello, my name is Effie. So look at this edge case. In case Nkadha is in a place whereby internet connection is very low, and she can't be able to use her phone number. So we have SMS integrated. This is an example of a recording we did while testing. So what she does, she has to do is just text this short code, which is our registered short code, and then the request comes to our system with a unique identifier, which is the mother's phone number and email. And from the SMS, she's able to enjoy the same privileges as a person who has a smartphone. As you can see, we have some commands there. She can maybe say status, and then this automatically speaks with the system without an actual smartphone. And there are also other commands like getting facilities, requesting for a doctor, doing an emergency, just using the SMS. Thank you.
We also have the facility dashboard, whereby the facility can be able to see all the patients that are in the hospital. They can be also able to see the emergencies. For example, we saw that Margaret sent an emergency, so we can be able to see that emergency. We can be able to look at all the alerts, all the patients in the hospital and their details, and also we can be able to look at the medical history of those patients in case they had medical history before. Also, we have the section for labor, whereby we have the pathograph for that patient, and also we can be able to see the referrals from different hospitals. This is whereby you can also be able to create the clinician, and we can be able to assign patients to those clinicians. Also, we have the clinician dashboard, where you're able to see your assigned patients, and you can be able to see the location of where the referrals came in. Thank you.
Is it working? Thank you very much for keeping time, and I like, that looks like a lot of work, but it's amazing. So I will give over to 2 judges.
Thank you very much. I'm Dr. Simon Peter Kayondo from Uganda. And since I'm a judge, I want to really understand which gap this app is trying to solve in the Kenyan system. Yes, because it looks like a lot of scheduling work. Which gap is there exactly that you're trying to address?
So Kenya loses mothers to causes medicine already knows. Of course, like for my example, I gave an example like incomplete abortion. We know how PPH is a burden, especially in Kenya. We have 3 gaps. Number 1 is the knowledge gap, of which like most women don't know the health education. So for a woman, especially in the pregnancy journey, in the first antenatal visit, the woman gets to get explained the danger signs in the health education. But if the woman doesn't get to like attend the ANC visits, she doesn't get to get all that information about the health education. But with this app, she gets to get reminders to attend her ANC visits. Also, the app, it has some health education where she is able to learn about all the danger signs pertaining PPH, pertaining preeclampsia. So if she notices the danger signs, she'll get to seek medical help. She also has an AI assistant. So if she has some certain symptoms, she might key in the symptoms to the AI assistant. Let me, for example, like Nkatha, she might like tell the AI, today I'm experiencing severe vaginal bleeding and severe abdominal cramping, of which the AI assistant will tell the mother, the woman, to seek medical help since it's a danger sign. Also, with our app, we're also able to like prevent we're able to reduce fewer missed antenatal visits. We also want to facilitate faster emergency referrals. For the nurses, see, there are some hospitals which are a bit lower than the bigger hospitals. So they don't have the full equipment to manage some complications. So the referrals might also be done between hospitals. So this will facilitate faster emergency referrals. We've also seen the postnatal care. So we want to also, for medical, on the medical field, we know that we really put effort on the antenatal and the labor, but we don't put a lot of effort on the postnatal. So we want to ensure we have better postnatal follow-up, where the mother will get reminders to attend all her postnatal visits, and to also get reminders for the baby, for the immunization schedules. Yeah.
All right. Okay, thank you so much for your presentation. Mine is in regards to safety regulation and ethics. Remember talking about an incomplete abortion, and we know there are situations where this incomplete abortion is induced, and induced abortion without medical advice in Kenya is illegal. So how are you addressing this? Because if I am a teenager who has procured an abortion and I have complications, how will you handle this? Because we mentioned safety, privacy and consideration, and also regulatory consideration. And maybe this person is unable to read or write in that literacy in terms of being able to apply what you have talked about in terms of the reporting. Thank you.
I don't know whether I fully understood your question. You want the linkage of the illiteracy of the girl, or
issues of ethics, safety, privacy? How will she divulge that information to someone to tell them, please type for me that I did an abortion and I'm having some bleeding which has been ongoing for 3 days? So issues of safety, consent, and illiteracy in terms of digital use.
Okay, so pertaining the illiteracy, Binti Care is not only limited to internet connectivity. That's why you have the USSD. Even if it's a teenager girl from the rural areas, she can access Binti Care app using the USSD code, of which it's the SMS. Also pertaining data, for the Binti Care app, okay, we weren't able to present the whole app layout. We have there's a linkage between the mobile app and the web app, where for the mobile app, it already has stored data of the woman. So if a woman or the client is supposed to go to the hospital, there's a linkage of the data to the web app using a QR code. But she first of all has to accept for on the healthcare professional, like whether they can get access to her data using the QR code.
And also just to mention, before you even access the user's information as a facility or a clinician, she first gets a notification through the application. Someone is trying to access your information. Should she accept it? Okay, it depends on her. She can reject or accept. If she accepts, the facility already knows who is coming, the medical history and all that. If she rejects, she will have to go there physically and maybe give it on her own.
Thank you very much. Again, lunchtime. The more questions you ask, the more lunch delays. We have 6 more to go. Yeah? So keep your questions, memorize their names and their faces, and then you can ask questions more. Thank you very much. A lot of femtech. So you have 8 minutes.
Standing on the
protocols already established. Good afternoon. My name is Maureen Kipkemoy. By God's grace, I'll be doing the part of the presentation for Team Elroy. So in Team Elroy, we have Lona Kiptum, we have Caro, we have Carl, and we have Edwin. So we're going to present our pitch, which is a Mama Toto link platform. And the platform aims to detect and possibly refer mothers with preeclampsia in early before complication occurs. So I know you're wondering, why are we presenting preeclampsia in a PPH conference? So preeclampsia basically doubles the risk of PPH. You can think about it in terms of the damage to the blood vessels. You can think about it in terms of magnesium sulfate, the drug that is used in the management of preeclampsia, which basically relaxes the uterus. And in PPH, you do not want a soft uterus. You can think about it in terms of low platelet count. You can think about it in terms of induction of labor. So preeclampsia is a very important aspect when we think about PPH. Now, 10% of pregnancies are complicated with hypertensive disease in pregnancy. So that accounts for 1 in 10 women. So it's basically a very huge deal in terms of maternal survival, and not only the mother, we're also thinking about perinatal deaths because of the stillbirths and of course the complications that occur with premature births and prematures. So preeclampsia, which is basically a hypertensive condition among the others, is largely preventable. However, because of late diagnosis and sluggish manual referral pathways, then these preventable issues turn into crucial emergencies, including PPH. And it's good for us to know that 99% of these maternal deaths do happen in lower middle income countries, including Kenya. So we ask ourselves, if they are preventable, why then are mothers still dying from them? So we'll talk about this in 2 things. 1, ineffective monitoring, and 2, inadequate decision support. Now, if you are like me, who comes from the rural parts of this country, you would bear me witness that mothers do not attend the 8 prescribed ANC visits. So when they go for 1, they will tell you, I have gone. You ask them, umeenda clinic zako zote? Nimeenda kabisa, nimemaliziwa kila kitu. I am good to go. Now, that is a problem. So the missed opportunities will bring us the complications of preeclampsia. How? In this room, and riding on the previous presentation by Professor Aris, he talked about the inability of us and most of the health workers to be able to judge objectively that this is 200 mils, this is 500 mils. The same way, you cannot be able to look at the mother and say her BP is 150 over 100, or her BP is 130 over 70. So we need something objectively to tell us her BPs and her risk of developing preeclampsia. So in terms of inadequate decision support, we have the FMF prediction tools that are widely used in the resourced countries. However, they rely on biomarkers that are quite expensive and they're not really available within the local setup. We can also think about the referral systems that are not very, very adequate, And our community health workers have limited decision support tools. So as much as they go to the mothers within the setups of the community and get data on ANC visits and the mother's current condition, that data takes time before it's actually linked up in a health facility. As well as the data is subjective to the mother's answer. So if I ask the mother, did you attend your last ANC visit? The mother says yes. So you do not have a way of verifying the same. So what is our solution then? So we are looking at a three-pronged kind of, So it's a platform that has a dashboard, it has a mobile application, and we have a smart digital wearable bracelet. So the bracelet is a device that would keep on monitoring the BPs of the mother. It would be a low-cost, smart color changing, so that when it blinks green, it means that the blood pressure is within the normal. Orange, it is moderately elevated, and red, it is dangerously high. Then we have actionable alerts that would be sent to the dashboard and to the mother's mobile application, together with USSD messages, just to amplify the alerts. Then, of course, we have the smart escalation, where we are looking at informing health facilities through alerts and routing, so that the mother can get the care they deserve. So we'll go through the care loop, but they'll do a demo. So the first thing, we'd have to register the mother. The mother would be registered in her first ANC contact, possibly within the first trimester. Then the mother's history and the clinical elements and parameters will form part of the AI prediction. Then the mother would be given the smart bracelet for continuous monitoring. Then we will have, the data syncing together. Then we have the clinical check, the uploading of the data by the CHW during the visits, and then the first referral. So the solution basically aims not only to bring technology on board, but also to bridge the three delays, the spotting of danger through the visual color and the vibration alerts from the smart band, then seeking care by our involvement with the community health worker, then the third delay through the solved digital referral platform. So the value proposition, the app intends to empower women through information. They are able to know when their BP is high. They're able to, it enables them to determine when they need care. And for the health systems, generally in a nutshell, will be able to reduce maternal and neonatal mortality. I know time is up, sorry. So that is how our bracelet will look like if we are given only 1 minute to go through the app. Thank you for your consideration.
So ideally, as explained by Maureen, is that we have a dashboard which will be able to be monitoring the mothers actively at the facility, and also the mobile app that the mother is using. So we'll be able to see how the app looks like on the phone, and then we also have the dashboard where the healthcare workers will be able to log in, will be able to feed the first inputs at the first ANC visit, and we'll be able to now calculate the risk and see other parameters. So So ideally for today, we'll use a wristband to showcase how we'll be able to monitor monitor the BBs of the mother continuously. So we'll be using this smart bracelet, smartwatch, or call it a smart band, to be able to see what happens in the dashboard when the mother is connected to the hub and the bracelet, so that for continuous monitoring. So I believe you can see from the dashboard, we have a section called Matters, and we'll be able to log in on one of the dashboard to one of our Matter to see what happens. So when we connect and we see, we'll be able to monitor continuously the BBs and the pulse to determine the risk as part of it.
Apologies, technology is not doing as good today.
To demonstrate?
No.
Yeah.
Okay.
Yeah.
All right.
Okay. Any questions as they fix the issues? You can continue.
Why is it not looping?
Okay.
Bring it up. It's coming. All right,
Okay.
it has come. Thank you.
So you can see from the readings, it is there is nothing for now. But when we trigger now, you'll see there is an active monitoring of the matter from the dashboard for our blood pressure, pulse, and the rest. So you can see it will be able to change after every 30 seconds. We'll be able to monitor continuously. So from this app, and we'll be able to monitor at the dashboard at the facility, because some matters may be ignorant to view the dashboard, but at the facility also we are able to monitor and see when there is high risks, or there is those high blood pressures and the risk that can build up the risk to that matter. Maybe. Yes, yes.
Thank you.
Okay, so thank you for the presentation. Yes. My name is Andrew Kahonge. I'm a computer scientist. Yeah, I saw on the slides you had some devices, some MCUs. So my question was, did you do that proof of concept? Did you actually make the devices as a proof of concept, or is something that you'd like to be manufactured and plugged into your solution?
The bracelet itself is yet to be manufactured. We will take all consent and approval from the right channels, and then we will be able to integrate to the 3 other systems that is existing in Kenya, because we have the Aegis that is working also for community, but then it does not have the active monitoring of matters. That is that part where we are actively monitoring from time to time. So we'll going forward, we'll have to seek for consent, take the certification from the DHA and the right approvals. Thank you.
Okay. While you make, the other team can go on top.
I want observation that culturally you're on the right track. I think all of us recognize that the Maasai bracelet really is echoing for us. Thank you.
Thank you very much. The next team I have to check the name. A smart digital maternal and newborn health, the Maternal Link Africa ecosystem. Jai Longeri will be heading the team.
Can we start? Thank you. Today would never be a better day to be here for us as a team, because this has been a journey that became a detour from something that we initially imagined, but we later validated from our clinical immersions. I have a story for you for how a woman who prepared from the first day that she recognized that she's pregnant, she got her bag ready, and the hospital was ready, or so they thought. And on the delivery bed, the mother is there, the baby is there, and the father is also happy. It's a baby boy, and in Kenya we know what that represents. But now we have a mother who is bleeding, and the blood is not available. Were we really prepared? The emotive banners were everywhere. We prepared for everything that we thought, but we missed out that important factor, the blood. It was there, it was available, but it was 30 kilometers away. What could we have done better? My name is Jennifer Nyambura, and with me here is a team. Jael Ongeri, a pharmacist from Kenya, and we have David Ajayi, a biomedical engineer from Nigeria, and we have Joel Ngushwai from Tanzania, our computer lead, and I am a biomedical engineer from Kenya, our motherland. We have the statistics in place. I don't wish to repeat, but here is the question that we were asking. We are in a course and a master's program whereby the whole idea is not innovations. I mean, we have so many brilliant innovators, but who are we innovating for? Are we sitting down and imagining that, oh, this is brilliant, I could actually take it to the market? Or are we going to the clinicians and the community health promoters to actually get what the problem is and solve for that? So in our clinical immersions from several institutions in Kiambu and Nairobi, we found out that what I just initially mentioned, the emotive banners were there. Even the teams were ready. And for example, what we know in Nairobi, if you're lucky enough to be in a, let me call it 5-star hospital, you have a team ready to welcome the baby. But the problem is, how ready are we with the blood? And the unfortunate thing is, the blood cannot be manufactured at the maternal unit. We need to have the blood ready, and that's why we came up with a solution called the Mala. And this is not a new or a replacement technology. It is something that is actually riding on the already existing ICHIs and all the platforms available to make sure that we have our 3 questions answered. We have empowered our health promoters, whereby a woman who walks in the health facility is able to be flagged on the risk. And the risk here is, are they prone to anemia? And our pharmacist will give us an insight on that. The other thing we are saying is, do we have a blood bank available? And for example, if this woman has been anemic, we know that they give us the IFAS. I am a mother. I was given IFAS, but I couldn't take IFAS until the last day, so they had to do a mitigated risk for that. How about these mothers who are like me, who could not hold that down? Do we need to just say that, oh, the IFAS would work, or actually have the blood ready for the D-Day? And that is the second question that we are answering. And third, but not the least, in Kenya we are prone to traffic. Like this morning, I guess most of us were in traffic. And when we're in traffic, the one thing that comes in is the boda boda. In Nigeria, he told me they call it the Okada. It comes through in such emergencies. How about we have a system where we have our ready boda boda or Okada to have this blood ready for the mother when they are delivering? And I'll invite Jael to take us through the fascinating story. Thank you.
Thank you so much. Like you've heard, I'm Jael. So basically, what our platform will be doing is flagging risk, and over 60% of women who have postpartum hemorrhage do so because they have anemia. So what our platform will be doing is coming up with a risk matrix, and especially for anemia, but we will also include other things like, is it a twin pregnancy, does she have preeclampsia, and all those other risk factors. But our greatest risk factor would be anemia, and this is how we are going to do it. We will use the common way of doing it, which is the pale lower eyelid, checking the palms, tiredness, breathlessness, and coming up with a subset of data to be able to flag a woman who could be at risk of having anemia. And coming up with a risk matrix and index so that a woman is either scored as low, moderate, or high. So what happens if a woman is rated as low, middle, or high? If she's flagged as a high risk for anemia and or postpartum hemorrhage, what we'll do is we will log them in. We will also be able to walk with them through this journey, ensure they go to the ANC, ensure that this mother has people who are ready to donate blood for her. Identify a blood bank near the mother, near where the mother will be able to give birth, such that they have this blood ready even 1 month before she gives birth. We have already cross-matched this blood, and we have done everything possible such that on the day of delivery, if she has been flagged as high risk for postpartum hemorrhage, we already have blood ready at the bedside, so that we don't have issues where we don't have blood and a mother is going through postpartum hemorrhage. So we will use the community health promoter in peri-urban and rural areas, and then they will be linked to a facility, and also link them to a blood bank. And now we will have an administrator who ensures that all this has been happening and they are following up on the cascade. So what does Mala do? An expectant mother is registered. She's guided through anemia risk. She's even started on the iron supplements. If she's not able to take them, because we know sometimes they cause nausea and vomiting, we are able to flag her and start the preparedness journey. So we also are very clear that this is a software as a medical device. That is why not just anybody will be given. So we'll ensure that its data protection is done and it's able to operate with the systems that are already there. And then health is not a one-man show. We have to partner with all these people to ensure this mother has been helped.
So good afternoon. My name is Joel. For the sake of time, I will take you through the demonstration how the system works. So we, as they were explaining, we have, sorry. Sorry, just to project. Okay, so this is the, first of all data in this platform are pre-generated, they are not actual data. So as they explained, we have four basic things, five actually. Number one is administrator who will be registering everyone. Number two is community health work promoters. We have clinician, blood bank, and delivery riders. So when you log into community health, this is the interface. So the community health will be able to register a mother to do screening and to do referral. The referral is done when the mother is being flagged. So for instance, these are the list of risk of mothers or the women that have been flagged. If you select one, it gives you all the history. So we don't refer a woman on the incident. We take the history, especially the risk history, on all the days that we've been taking all the readings. And then this is the graph that will tell us if we should refer or not refer based on this data. And then we can do the referral on the system. So if we want to refer this woman because in high risk, we can just update and then do referral, do the everything. And then number 2, we go to clinicians where they can also receive the referral from the community health workers. And then the community health workers will not be able to see the blood request. The only people who will be able to see the blood request are the clinicians and the blood banks. So here, the community health worker will search for the blood group and then nearby. So these are nearby places where they can have Kenyatta National Blood, Lake Regional. So the system also recommend nearby blood bank, and then you send the request. After sending the request, you come, the blood bank receive the request, they log in, and then they come to blood request. So if they have blood, they can accept or decline. So if they accept, now they can assign a rider. So the rider, we have predefined riders, and then assign a rider. Then a rider will get a notification. This is a notification. So the rider picks the blood and then start delivering. So basically, this is how the system works. Yeah, thank you.
Thank you very much. I think I need to go for a computer science class. Again, today I'm also in class for that.
So you can scan the QR code and then you can keep interacting with the system.
Oh, awesome. Yes. Thank you. One question. Okay, there's someone I missed there, and then I'll come down.
Thank you, team. My name is Professor Wanyoro, obstetrician gynecologist, and I'm happy you guys went through a clinical immersion.
Thank you.
Maybe my question is for you to clearly tell us what is the need, because you seem to have several things or needs that you want to solve, and I think a bit lost because is it availability of blood for that patient when that patient needs the blood? Is it risk stratification of either anemia or risk of PPH, or is it a need to prevent the occurrence of PPH, or is it a need to reduce anemia in the society? So I think we need to know what is your system, what is it addressing?
Thank you, Professor Wanyoro. I'll take that, as my teammate also does. We identified a gap, and there are several gaps, and one is leading into the other. For example, we could have made the blood available early if the risk was flagged way earlier in the pregnancy. And how are we doing this? 2 ways. We get a donor for the mother, and we cross-match that way before the EDD. And then during the day, we have the blood available, and we also have our Okada guy deliver the blood in time. Instead of where we have, like in Kenya, you will find yourself, the mother is there's no blood that is also available in the banks. Now we have to look for people to come and donate and all that. So this is what we are calling a coordinated preparedness. I don't know if that answers your question.
My name is Parit Mehta. How are you ensuring the safety of the blood when you're transmitting it from place to place? I don't think you've identified where it's going to, how will the rider know, how will you ensure that it's delivered, and the safety protocols around that?
I will answer that. So what we will do first is, for the Okada guys, we will have to train them and authorize them and give them permits. So we will not just be giving any rider. It's riders who have been trained on cold chain, because you know blood is cold chain. So we will ensure that. And then we are trying to work with blood banks so that we ensure that the blood we have is safe, and we are working with the hospitals to ensure that they give us a requisition form. So if you interact with the system, you will see there is a place where the hospital does a requisition and it goes to the blood bank. Then the blood bank is able to accept the requisition. So it's a coordinated preparedness. We are not, and we will ensure that it's done within cold chain, and the people who do the transportation have been trained and they know what to do.
What's the failback in case of a decline? You've only talked about the success factor. What if the blood bank declines, then what?
So yeah, as you saw in the system, there are nearby blood banks. So the blood is not requested on time of delivery. The blood is pre-requested before the mother is taken to the hospital. So if one blood bank say we don't have enough, we look on the one that is nearby again to see if there is another one nearby which has a blood. So all the blood banks will be, the moment that the medical personnel search for the blood, maybe blood group A plus, they look on available blood banks which have the same blood A. If blood bank number 1 say they don't have, we look on the other one until we find. It's easier because all of this is being done before the mother is taken to the hospital.
If I can also add to that, remember we said when the mother is pregnant, they identify a donor in the early stages so that this blood is available for that particular donor, so that we close that gap of the last minute there is no blood for mother A, B, or Z. Thank you.
Thank you very much. One last question as Team Mama Care go to the podium.
It's not actually a question, it's a suggestion. In Uganda, we have this practice. Every morning they give a blood availability status from all the blood banks across the country. So as that day starts, you have information on what everyone has. And so you don't have to struggle looking around for who has what. If you could incorporate that within your innovation, I think it may make a lot of sense.
Thank you. Yes.
Team Mama Care, are they here? Michelle?
They're doubling up as transport, and they're also giving blood donation.
Yes.
We'd be happy to partner.
Thank you very much. I am not seeing Team Mama Care, so I will go to the next group, Mama Lishe System. Mama Lishe, if they're not here, Mama na mtoto. Okay, welcome to the stage. You have 8 minutes. I will warn you at 2, at 1, and I'll stand up when time is up. Good luck. Thank you.
Good morning, everyone. Oh, good afternoon. Sorry, it's afternoon. So, if you are a pregnant mother, 8 months pregnant, and you notice that the baby has not moved for several hours, will you recognize this as a danger sign for you and also for the baby? Would you know what to do, what the next step, and who to call? So for Kenyan mothers, they don't really recognize these danger signs, not because the information does not exist. It is actually on page 7 of the purple booklet, but more oftenly, the purple booklet is more rather passive. It does not alert, it does not inform, it does not send any reminders, and it does not take action when it is actually needed. So my name is Tanya Ashley Kopio, and together with my team, we bring a solution for that. Mama na Mtoto Plus. Okay, so in Kenya, from the statistics we've all got, mortality, neonatal and maternal mortality is at a very high risk at 355 per 100 live births and at 21 neonatal deaths per 1,000 live births. So for this, the major causes are often preventable. The major causes include postpartum hemorrhage, neonatal sepsis, maternal infections, and hypertensive disorders like the preeclampsia and eclampsia. So for these conditions, they don't just begin from anywhere. They usually often begin as warning signs. So for Mama na Mtoto Plus is to capture those warning signs from the onset. So what Mama and Mtoto Plus does is to notify the mother of all recognized danger signs for maternal and neonatal based on the Kenya Ministry of Health. Once they are able to detect these warning signs at an early rate, it will help to prevent these complications from becoming life-threatening and leading to mortality. Our application also helps mothers to keep track of antenatal and postnatal clinics as it sends timely reminders to the mother and to the CHVs as well. So this will help the mother to monitor the baby. This will help constant monitoring of the mother and the baby. And then to finalize, our goal is simple: early recognition, timely care, and overall reducing maternal and neonatal deaths. I'll pass the stage to our research lead.
Good afternoon, everyone. So I'm Mark Njeru. As the research lead, I wanted to know the challenges the mothers face during pregnancies, during childbirth, and after delivery. We reviewed the Mother and Child Health booklet from a mother from Kitengela Sub-County Referral Hospital, designed questionnaires and collected responses from the mother, nurses, and the community volunteers. One thing became clear: the purple booklet works well during clinic visits. Once the mother leaves, routine follow-up becomes difficult. The community health volunteers wouldn't know when the mother has missed an appointment or when the mother develops the danger signs until the next clinical visit. We also noticed that most monitoring sections in the purple booklet were left blank, such as the symptom page was left blank, the danger sign page was left blank, and the counseling sections were untouched, thus leaving the health workers with little information between appointments. These findings guided the design of Mama na Mtoto Plus. Instead of replacing the purple booklet, we built a system that keeps mothers, the community health volunteers, and nurses connected through either an USSD code, an app, or an SMS, making it accessible to mothers with either smartphones or basic phones. It builds on the booklets by improving follow-up after clinic visits, allowing mothers to report danger signs as they occur, and helps health workers receive updates before the next clinical visit. As one health volunteer from Nairobi stated, it will allow me to respond immediately to emergencies and prioritize my daily visits based on who needs urgent care. I would like to welcome my colleague Xavier to take us through the app demo.
Okay, good afternoon. So I would like to show you what Mama and Toto Plus actually does, because a live demonstration is better than any slide. So first, for instance, we have Amina, who is in rural Kiambu. She is 28 weeks pregnant, and she opens the app. She has a view of the homepage, which shows her pregnancy week, her ANC schedule, and also daily insights, and also the baby's status. So today, Amina opens the symptoms tab. On the symptoms tab, it's separated into two, one for her and one for the baby. Amina is experiencing heavy bleeding. She taps on heavy bleeding. Watch what happens. One, an alert is sent to Grace Mudhoni, her CHV. Then Kiambu County Referral Hospital is also notified. And also the partner, James Wanjiru, is also notified via SMS. All this happens in under 3 seconds. Then we have the second instance, Fatuma. Fatuma is in rural Garissa. She opens her basic Nokia phone. She dials *384# for the USSD. Then she clicks option number 3. When she clicks it, the same thing happens. An alert is sent to the CHV. The hospital is also notified, and also the partner, James Wanjiru, is notified. So Fatuma has no smartphone, no internet connection, but still gets access. So it's for every Kenyan. Then we have the clinics tab. On the clinics tab, the mother can view her ANC. He can track her ANC visit, the one she's supposed to attend and the one she's attended. It also has the vaccination schedule. It also has the laboratory results from the ANC visits and also the blood pressure trend. All this is just the purple booklet, active and connected. Then she opens the lunch section. The lunch section delivers health education to the mother. It delivers the health education also in pictorials for the low literacy mothers, and also has a section for the anonymous section for the teen mothers called secret chats, where they can send anonymous messages and receive answers from the CHV nurses or doctors without having to ask directly due to certain factors such as stigmatization, and also nurses could judge them for not taking note of certain things in pregnancy. So then you have the profile section. In the profile section, Amina can view we have the registered CHV, Grace Mudhoni. We have the Kiambu County Referral Hospital, which is SHA accredited or Linda Mama accredited. We have the support, James Wanjiru. All these are notified on the danger alerts. Then you have the pregnancy history. The pregnancy history could be used during the delivery time to identify such problems that may have recurred from the previous pregnancy. Then you have Grace Mudhoni. Grace Mudhoni is the CHV or nurse. She opens her dashboard. We have the dashboard where she can view the mothers registered under her. We have the clinics, the mothers who attended the clinics, the mothers who missed the clinics, and also the alert she has received on a certain day. So all this, Amina doesn't need a lot of paperwork and records. She can view it directly, and she can get the information in real time. Then we have the feature. We have a feature for the Swahili. This feature allows every Kenyan to access the information, also the low literacy and Swahili speaking Kenyans. So this is an app built for all Kenyans. And also everything you see here is connected to the Kenyan infrastructure, the district health information software, the electronic community health information system, and the social health authority claims platform. All this is built to the health level 7, fast healthcare, interoperability resources standards from the architecture level. This is not a foreign solution adopted for Kenya. This is a Kenyan solution built on Kenya's own systems. So I'd like to invite my community lead.
Good afternoon. My name is Tasha. I'm the community health lead, and I'll be talking about the community adoption plan and how Mama na Mtoto Plus connects with the existing Kenya digital system health systems. So for the first community adoption plan is to start at antenatal and postnatal clinics. During the mother's first visit, the CHV or the nurse introduces the mother to Mama na Mtoto Plus. The CHV or nurse registers the mother, and if the mother has a phone, as my colleague has said, she can download the phone, and if not, she can use the USSD code. Another community adoption plan is through community meetings and support mother groups involving families, because pregnancy is often a family decision. So Mama na Mtoto Plus connects with numerous national systems in Kenya. For example, the electronic community health information system and hospital management information systems by providing pregnancy-specific monitoring, reminders, and danger alerts. Through KHIS and HL7 FHIR standards, Mama na Mtoto Plus can securely exchange patient information from hospitals and other health facilities. Mama na Mtoto Plus also complements SHA by directing mothers to accredited facilities and ensuring timely care. So basically, Mama na Mtoto Plus is practical, scalable, and aligned with Kenya's existing digital health systems. I now welcome my colleague, who is the business and sustainability lead.
Good afternoon, everyone. My name is Faith, and I'm the business and sustainability lead. I will take you through the process on how we bring Mama na Mtoto Plus to life and how we scaled it to the long-term sustainability. We have designed a 12-month discipline structured plan around the first prize, 300,000. It will take place in 3 phases, where the first phase will take place within the first month and that month. Here we will build and test our MVP, pilot launch to 3 Nairobi and Kiambu facilities, and also support 200 mothers and onboard their community health volunteers. In the second phase, which will take place between the 4th month and 8th month, we will expand to Garissa and Kisumu County. We test our system in highly remote, vulnerable, and pastoralistic community. Here, the district health information software will go live. Then the last phase, which will take place between the 9th month and 12th month, we will ensure we have 3 county coverage, ensure we have secure Ministry of Health endorsement, and support over 5,000 plus women. Our budget is strictly allocated to ensure maximum impact, with 50% going to the Android MVP app, 10% for building the USSD using Africa Talking APIs, 16.7% for onboarding and training community health volunteers, 6.7% for 1-year server hosting, 10% for localization of Swahili content, and 6.7% for contingency. We are not just building, we are deploying responsibly. On the sustainability part, Kenya has 1.5 million annual pregnancies in the 47 counties. They don't need a new infrastructure to reach them. Mama na Mtoto Plus is built on already existing foundation. We plug into the already 100,000 plus deployed community health volunteers network. We use Africa Talking APIs to send USSDs and SMS to all networks. Our analytics feed directly into the Kenya Health Information System, and we align with the Social Health Authority and Linda Mama policy for the clinical care pathway. Our sustainability is clear. We move from pivot development to county adoption, which introduced public funding. Then we move to leverages with UNFPA, which is the United Population Fund, and also WHO Kenya. We can also partner with Safaricom for free USSD rates. SHA integration can also take place here, where they allow health facilities to claim reimbursement on digital health record. Mama na Mtoto Plus is not a short-term project. It's a sustainable and a living improvement to the digital health system. Thank you.
Thank you very much. Include 1% for fine for extending the time. Let's limit a question for the judges, and then I can go to the rest. because of time. Okay, the rest. One.
So thank you for the opportunity. I have two questions. The first question is, I saw like once you click like you have severe headache, there's that process. I would like to like understand what is actually happening there, and what if me as a mother, I don't want my information to go to that doctor, to maybe to a certain doctor or facility. And also for the SMS and the SSD, I want to understand like how do you actually verify that this is Fatuma who is in our system communicating and not just any other person, because we are in an era where cybersecurity is actually something that we need to check on. And also another thing, how do you ensure that as your users communicate, they're actually communicating to your actual system and server and not any other system? Because a third party may interfere with that and it may cause data loss. So basically, how you are handling data loss and privacy. Thank you.
Okay, thank you for the question. I'll give you an answer. So first you asked, when someone clicks, let's say a symptom called severe headache or heavy bleeding, what happens? So first, when they click on the symptom, a post request is sent to the backend server. After it's sent to the backend server, it identifies the CHV or nurse registered under the mother. It sends the CHV, and after identifying the CHV, it triggers Africa Talking API. Africa Talking API will send an SMS to the mother, to the CHV registered on the phone number. Also, secondly, a simultaneous alert with the logs, with the timestamp and the location of the mother will be added to the mother's health profile. This will also notify the facility. And also, we have the CHV dashboard, which is updated in real time of the alert that the mother sends, which will be when the CHV responds on the dashboard, it will unflag the alert. And then the second question, you asked about concerns of the security of data. So first, Mama and Mtoto Plus will comply with the Kenya Data Act of 2019, which says that the mother can register explicitly with consent and also can request data deletion. So if the mother doesn't want to register or to register on a certain facility or a certain nurse or a certain doctor, it will give her consent to choose before registering. And also on the issue, or adding on the issue of data security, on the CHVs or the nurses, the data is role-based. So that means that the CHV can only view the mothers registered under her. And also another CHV can view different. They cannot share the same information. So that will protect the data from, or the information from, leaking. And also, can you clarify on the last question?
How will he be able to know it's from Fatuma and everything in the USSD?
Okay, your second was to identify Fatuma. As I indicated earlier, when she taps on the alert, it sends the request to the backend. The backend has the list. It will identify and it will tell the CHV that a certain alert has been sent from a specific mother, and also the timestamp and the location of the mother will be added to the mother's health profile. So the CHV can confirm that a specific mother, let's say, example Fatuma, has sent an alert from a certain location. Have I answered your question?
Thank you very much. I think you answered all the questions in all those time you took. Thank you very much and good luck. Next team is Neon Optics, a unified optical diagnosis platform for maternal and neonatal health in low-resource settings, led by Taekwondo Sembo. Welcome to stage.
Mothers die due to breeding, and we know exactly how to stop it. Good afternoon. My name is Tagondwa Sembo. I'm a biomedical engineer and a Malawian. Today, I'm with Team Neon as their team lead, with my team, Mark Matakili, a biomedical engineer from Kenya, and Dr. Salisu, a medical doctor. 1 out of every 5 maternal deaths in the sub-Saharan Africa occurs because of postpartum hemorrhage. Here in Kenya, about 1.14 million births occurs each and every year. But the good news is about 98.6% of these births occurs in facilities where uterotonic drugs are given. Oxytocin, according to the World Health Organization guidelines, it is the first line drug that is given to a mother in order to stop bleeding after they have given birth. So what oxytocin does is that it facilitates contraction of the uterus, hence stopping bleeding and also preventing PPH. But now let me walk you through the journey of our clinical mission. We went for needs finding at Kiambu Level 5 Hospital and Thika Level 5 Hospital. At these hospitals, this is what we observed in the labor wards. Childbirth begins, a mother gives birth. Within the first 3 minutes, oxytocin is administered. 10 units, those are the standard. If 10 units does not work, they double the dose, and this continues until the bleeding stops. If it works, that's good enough. But then what happens if the oxytocin has been given but it does not work? Maybe because it is of substandard, it has lost its potency, or maybe it has degraded. And that is where Oxystra comes in. A mother today can die even though they have been given medication. Ineffective oxytocins fails everyone in the chain, starting from the mother who has been given the medication, the nurses, the doctors, and the midwives that are doing all they can in order to stop the bleeding. Again, even the consultants are also affected. I'm so sorry, I've gotten a glitch. Okay. All right, sorry, we will not be able to present the slides because the laptop has gone off. All right. Okay, all right. So, what happens is that now when they're in the labor ward and now oxytocin has failed to work, what happens? There's a study that was conducted in Kenya, Tanzania, South Africa, and even Nigeria. It is one of the best answers for ending PPH here in the sub-Saharan Africa, the E-motive. But again, there's evidence from E-motive that substandard oxytocin contributes to about 20 or 30% of postpartum hemorrhage. This is a very big issue here in Africa. Here in Kenya, suppose oxytocin has not worked, the Ministry of Health recommends that we switch to carbitoxin. But now, the logistics that come in, the cost, and even the regulations, they hinder the use of carbitoxin. A study again, there's evidence that shows that about 33% of the oxytocin that is available even here in Kenya, and if we go to other countries like DRC, about 80% of the oxytocin that they have in their hospitals is not, is already dead on arrival. And because of this, it means even when they're using it, the chances that it's going to work is very low. It is said that 6 out of 17 oxytocin that is used or that is available in our markets is already lost quality because oxytocin is heat sensitive. So it means any mishandling within the transportation will affect it. It survives at least 2 to 8 degrees Celsius. But then if we look at our African context, sometimes we're unable to achieve this kind of a cold chain. Wait.
Thank you. I will take it over from here. So based on what she has presented, that informs our concept of developing Ozistra. So basically, Ozistra is a quality assurance system at the bedside. So what we realize is that for the regulatory bodies like PPB, they can regulate those drugs as they come into the country. However, at the bedside, it's very hard for them to track it. And just like there was talk today, there's a new consolidated guideline which recommended that quality assured oxytocin should be used as first line. For countries that cannot assure quality, they should switch to carbetocin. So that's why we come up with Ozistra. So Ozistra works based on 3 principles. The first principle is infrared red light transmission through the ampoule. The ampoule must not be broken, it's still intact. So through the refractive index, we'll be able to determine whether the oxytocin is qualitative, authentic, or fake. And then through the second optical system, which is transmission of infrared light, there will be transmitters which will measure the concentration of the drug. Is it up to the 10 international unit or is less than that? And then there will be scattering of light when it has started degrading. This is how we'll be able to figure out if this oxytocin has degraded. So we tried to conduct a simple survey. Even though it was a very short survey, we just had 13 responses from clinicians from both Nigeria and Kenya. So 8 out of them said they had suspected that the oxytocin they used was not working actually. And then we will kind of like ask them about the confidence of the oxytocin that they were using, and just 3.1 over 5 average confidence was there because majority of them were neutral in the confidence of the oxytocin. And then we asked them, will they use a bedside potency verifier before administering oxytocin? 92% said yes. And then we asked them if they will be willing to recommend to their facilities to get this device, and 100% agreed that they want to get it. So this user input informed our design inputs. So we came up with we are going to build a system that will be able to access this oxytocin in sealed ampoules. It will be easy to use, and then it will be repeatable use, not just one-off use, and it will be handheld and easy to move around between wards and the theater if needs be. So every degraded ampoule is a hemorrhage every degraded ampoule cut is a hemorrhage that never escalates. So that's our target. So the simple thing we are trying to do first is try to screen this oxytocin. Every ampoule before it gets used within the labor ward is being screened, so we're able to catch the degraded oxytocin early enough, and then there will be escalation and proper handling of this degraded oxytocin. So there is no more illusion of safety which exists currently, because most of the clinicians believe the oxytocin they have in front of them is already effective, which is not the case from what studies have shown. So by that we are able to abate, so there are fewer PPH cases and fewer near miss, less blood loss. And then so every existing tool screen quality and non-verifies potency. So this is based on the analysis we did on the current existing solutions out there in the market. They are basically for field use. They have left a gap within the bedside, so they are able to determine if this is oxytocin. However, they cannot tell you about the quality or the concentration of this oxytocin as it has been tested in the field. So okay, let me just scroll this. So there is a recurring need at every facility, but starting with Kenya. So we have 1.14 million facility bats in Kenya, and then about 30 million bats in sub-Saharan Africa annually. And there's a repeated use of this this consumable free device will be used to test the oxytocins that are there. So who buys this? This will be for the Ministry of Health and county procurement, face-based and private hospitals, and then global maternal health funders. So we are trying to build only one platform for every fragile injectable. So we are starting with oxytocin, but we are not just going to restrict ourselves to oxytocin, because what research has shown is that most of these drugs in Africa, there are fixed drugs out there substandard, leading to distrust among the clinicians. And then there is a manufacturing defect, which was common in the emotive research, which discovered only 6 out of the 17 oxytocins were actually made the standard. So there were manufacturing defect, and then inventory management was also a problem. So the same thing with his stable carbetocin. Within when it is within 30 degrees, it can last for 4 years. But if the degrees is above 30 degrees, the timing reduced. So with this device, they can properly there will be proper inventory management for carbetocin. And then we are looking for vaccines, protein-based vaccines that also degrade when they are out of the refrigerator, and then insulin and other biologics. So we have like a clear route from prototype to approved bedside device. So we have already filed our provisional patent. We are looking at the PPB classification. This is a class A device. And then we are looking at the regulatory pathway, which is the PPB Kenya Medical Device Guidelines. And then, so what we are trying to do is put a potency answer in every clinician's hand. So the clinician will be able to validate. I will be able to validate this. It will be integrated into the system, and then it will scale across 3 counties for validation. So this is just a simulation we did for our sensors. This sensor shows that if they are working properly, we'll be able to differentiate between water and oxytocin, authentic oxytocin, and the one that has degraded. So these are the guys that built it. So I would like to briefly show you a demo of how our device works. But before why did I put the oxytocin? It's here, it's here. Okay, so we started our design by designing what is called the optical chamber. So this will be the seat for the oxytocin. This is the most important part of the project. So the oxytocin goes into the optical chamber. By the right here, this is where we'll have our lights, the infrared and the red LED that will be measuring the refractive index, as well as the IR transmission. On the right side here, we have 2 sensors. One is for the refractive index down here, and then we have one for the IR transmittance. At the back, we have another sensor for scattering. This will be able, all this data collected will be able to tell us the percentage degradation of this oxytocin, the concentration, and its potency, and whether it is authentic or false oxytocin. So we'll now to the assembled device. We'll now take you through the assembled device.
Okay, thank you. Here with us, we did a first iteration of our prototype of our device, a bedside device for measuring the potency of oxytocin drug. Yeah, so we used the sensors based on just the way my colleague said. We did a simulation. We went ahead to do the design of the PCBs, and then we did this first design. This is the casing. Yeah, so I'll just go to power on. Its screen is very small, and then, so I don't know. Okay.
So unfortunately, the cameras aren't here. Okay, we are using the USB. We can't move it. Can you zoom the cameras? Is it possible?
Is it Okay. So when you power it on, this is just an interface of showing the oxystra. So this is the chamber that my colleague just described. So you insert here the oxytocin ampule, and then now the entire of this housing has a microcontroller that is able to coordinate the transmission of these lights. It will start do the scanning, first emitting the red light that will pass through the ampule. We are basically just testing the reflectance of these the oxytocin that is in place. So the angle of which the deviation angle of how the light passing through the ampule, it is the one that will be able to tell us how how efficacy this drug is. So basically, this is just the very first iteration. And yeah, so unfortunately, I don't know if we can see, but the chamber is very small. We are trying to make it as small as possible so that it's an easy device to use and easy to carry and also easy to purchase. So there, when you turn on, there's a red LED light here within the light chamber that comes on first, and then now there's an infrared light that will be able to also pass through now. The sensors on this other side are the ones that the results that will be transmitted back to the microcontroller, and we'll be able to get our results here at the screen telling us what percentage of efficacy is this drug. So we believe this is a solution that will be able to give a bedside quick results about how efficacy this oxytocin drug is it to be potent to use for our mothers. Thank you.
Thank you very much. Apologies for that. I thought it shook you a bit, so I wasn't favoring. I gave them a little more time because of that. We all have gone through something like that in our past. Any questions? Two. The amount of questions that you ask is you and lunch. Okay, I've seen two hands.
Okay, thank you for that presentation. It's quite impressive that you're able to do the prototype. Yeah. So my question is on the same. Did you run tests for accuracy and precision of that device with many samples of oxytocin at different temperatures? And what are the values that you got from that?
Okay, so okay.
All right, thank you very much. So one thing we didn't figure out is that this is just a working principle. We did assemble the sensor like we showed. Unfortunately, the circuit did not work for the sensor. So we have to change our plan to just show the working principle. So our plan is, if we get a sensor that works, there are various options that we are looking for, the basically CMOS CCD sensors. There are various options, and then if we get the one that works, we are going to validate it under, like you mentioned, different temperatures, and then we subject this oxytocin to a control environment to see if we can simulate the degradation, and then test to see how this responds. But for now, we don't have any value in terms of validation. All right, thank you.
Okay, just to add on that, as you can see, we did hand soldering, and these components are very minute. So there's a lot of noise based on some hand errors, the human are true errors. So when you're doing hands, there are such kind of errors. But in our next iteration, we are planning to using digitally controlled PCB designs that we just give them the design, and then they accurately print our circuits, and then we'll have a more perfect design with less noise.
Okay. Thank you very much, team. Dr. Hilda Gikunda, Kenyan. So I like that you're working to solve this problem of substandard or inert oxytocin. My concern is at the point of solution. So by the bedside, healthcare workers are overwhelmed. Could you consider taking this to the pharmacy, because they're actually the custodians of all meds at the hospital level, so that if possible, either at the point of them receiving the drugs or dispensing, therefore they could verify, so that when the prescription is issued and the nurse goes to pick the meds from pharmacy, they're already getting something that is viable. Then there's the aspect of maintaining the cold chain. This also needs to be brought up because it's a very important aspect. All cold chain medicines are non-returnable. So once a facility receives the cold chain meds, they're theirs, whether they are viable or inert. So that's another area for consideration, and also future thoughts about doing this at a larger scale, so that if I am buying, my goodness, possibly 5,000 vials of oxytocin for a busy level 5 facility, how does this work out? Thank you.
Okay, thank you for those wonderful questions. Um, just to address your first question on moving it to the maybe lab or pharmaceutical setting, this one at first, we are just first of all, we're just trying to prove how like we can use one ampoule to prove that one ampoule can be verified using this device. But we're also thinking at a larger scale, we can have a bigger machine that we can place in multiple samples, and it's able to, okay, sorry, and it's able to verify all the entire batch if it's potent, the entire batch if it's potent. But again, the reason why you're also placing it at the bedside is there are issues. Yes, you received a batch that is very accurate and it's working fine, but maybe your storage conditions have affected one or two or a certain section of the drugs. And then you don't know if this drug is efficient. So you end up injecting into the patient. You don't see its effect. You keep on adding the dose, and then it's the issue of PPH that you are running against time. So at the end, if you can have a device that is able to tell you quickly that this drug is not working well, you can easily do away with those drugs and or come up with other measures that you can use to address the PPH aspect so that you don't run into those issues.
Let me add to that briefly. So you are right, we could have done it at the pharmacy level, but then when we did our interview, or let me just call it a survey, so one thing is that they restock this within the labor ward fridge. So you have been dispensed from the pharmacy qualitative oxytocin, and then you had issues within the labor ward. So we asked the doctor, so are they willing to take some time out of their day without disrupting their work to test if they suspect that, okay, there has been power cut or anything that will have degraded the oxytocin? And they said yes. So we asked them like how long. They said if it can give us result within less than a minute, we will be able to do that. So that's what we are working with right now.
Thank you very much. Before you ask your question, you can go and find them after to see how it's working as well. If you want to see the LED lights and what the message is. I would like to again call the two groups that I skipped. A smart digital maternal and newborn health ecosystem, Michelle. Going once. The second one, Mamalisha System, led by Pendo Suzanne. Going once. It's a small room, so I can only say once. I'm not going 3 times. Yeah, anyone who knows them, pass my regards. We would like to give everyone a good opportunity, especially in a hackathon like this one, because a hackathon is not a sprint. We were meant to stay here for a while. But so one more question, and then I'll hand it over to you.
My question has already been answered, so I'll just pass.
Yeah, thank you. You tried to cut me out, but fate was on my side. We are here wondering what the sensitivity is of that test versus the gold standard, which would be the biochemical test. 2, what is the projected cost of this bedside implement? I know you haven't finished it, but you must have an idea, because if it is too expensive, then we can't have it in the facilities.
Okay, first to answer your cost question, this prototype, it has costed us about less than $50. Buying the components, it has costed us $50. So we are projecting the cost can't go beyond. It can be within $100 or less than $100. So that's the projected cost. Then talking of the sensitivity, we are trying to make sure that this, the Oxystra, its concentration within the ampoule is very small. and we are really trying to ensure that the light passing through it has the capability to capture the concentration of the oxystra. Based on our design, as you can see, or maybe you can use this one, the ampoule is inverted. So inverting the ampoule, it distributes the concentration of the actual oxytocin. I think you've seen in hospitals before a doctor breaks this sample, they have to shake it so that there's that equal distribution of the actual content. So that's one way we're trying to ensure that the sensitivity or the data that we are capturing is really accurate. Yeah.
Thank you very much.
Yeah.
Okay, thank you very much. It was a pleasure moderating this session. As I said, it was a good time to walk up and down the stairs because I was freezing and now I'm warm. So to all the teams, Moralink, I like that you involve the community a lot. Binti Care or the education aspect, I think we normally miss that sometimes when we create dashboards. And also I liked that many teams are considering the GSM and going on mobile because not everyone has internet. We have Mama Toto, again, the USSD, and the dashboard was quite intuitive. Again, as I said, I've gone back to school. Maybe if you tell me to make an app right now, I'll have to Google it. And then Maternal Link Africa as well, where you're considering blood and what effect is there. It was very good to know that clinical immersion has an effect on your product. When it comes to Mama Namtoto, you were very thorough that you did not get questions. So good job. I even, like, if you look at my notes, it's empty. So good job. And then we have, last but not least, Neon Optics. You were very brave into continuing after the computer went dead. I would have stopped. But continued and you showed us, you came up with a prototype, and good luck in the next. I am very proud I'm a medical device design lecturer. So I'm very proud to actually see some of this work being done without me mentoring them, without them asking me. This was just them. So congratulations everyone and good luck. And I will hand it over back. Thank you.
Good morning, ladies and gentlemen. But you haven't eaten lunch. After lunch, then I go afternoon. Thank you very much. I'm impressed, really, really impressed. And as I was seated there with Prof. Obimbo, I suggested we should be having this hackathon maybe twice a year or something like that. Lakini mukileta pesa, leteni pesa. Thank you. Congratulations to all the teams that presented your ideas. I think all ideas are really, really nice, but we will leave it to the judges to let us know who are the ones who have taken the first place, second place, and so on. But I am impressed. We are impressed that we are thinking not even outside the box, because even the box, if you put it here, it may attract you into it. So you've thrown away the box, and we are thinking without a box. And I think that is the way we should go. So for all the good work that you've done, let's go and replenish the energies. We are a little bit late, but I think that was worth it. So we go for lunch. We are supposed to come back at 2:30, and it's 10 to 2 or thereabouts. So we'll come back at 2:45. 2:45. We still have quite a number of presentations to do. So please, let's go and have our lunch. Tujaribu kuharakisha kidogo. Hopefully the serving place will also help us, such that we are back at 2:45, so that we continue with these fantastic ideas that we have. Twendeni lunch tafadhalini.